Hi, Dr. Basu.
We are live.
Hello. Good evening, everyone. I welcome you all to this webinar on Uveitis For All. On behalf of the Academics and Research Committee of the AIOS, I welcome you all to this subspecialty webinar. This year onwards, ARC has taken on this new initiative of organizing webinars in association with various subspecialty societies. These webinars are designed to update the general ophthalmologist and give them an insight into the various subspecialties. So today's webinar is in association with the Uveitis Society of India, and it's called Uveitis For All. I'm sure it's going to be a very informative session, which is going to give a lot of practical tips that you can use in your day-to-day practice to all the ophthalmologists. And I heartily thank the Uveitis Society of India for collaborating with ARC AIOS. And I thank all the office bearers of the Uveitis Society of India who have been instrumental in drafting this webinar. The President, Dr. Kalpana Babumurthy, the Vice President, Dr. Padma Malini Mahendradas, and the Secretary, Dr. Sudarshan. So a big thanks to all of you for this excellently drafted webinar. I also thank all the other executive members who are here with us as part of the expert panel. Welcome to you all, and thank you so much for your esteemed presence here. I'm sure it's going to be a very enlightening experience for everyone. I also thank the audience who has logged in. I request everyone to make this as interactive as possible, so please keep your questions coming in the chat box. One very interesting concept that we've introduced in these webinars is the concept of Saransh, wherein you'll be getting articles, gists of articles from various journals, which you can use in your day-to-day practice. So watch out for that. With that, I hand over the proceedings to our moderators for today, Dr. Somshila Murthy. Dr. Somshila has been, she's had a very long stint at the L.V. Prasad Eye Institute. She's been someone we all looked up to while I was there. And now presently, she's the director and heading the cornea, cataract, refractive and uveitis services at the Shantilal Singhvi Eye Hospital in Mumbai. Dr. Padma Malini Mahendradas is the head of the uveitis and ocular immunology services at Narayan Netralaya, Bangalore. So welcome to both of you. And with that, I hand over the proceedings to the moderators, Dr. Somshila and Dr. Padma Malini. Over to you.
Thank you, Dr. Tinku. Very good evening to all of you. We welcome you all for this Uveitis For All webinar. At the outset, we would like to thank ARC President or Chairman, Dr. Prashant, Dr. Tinku, and the entire team for giving us the opportunity from the USI side to host this webinar. And I invite our expert panelist, Dr. Biswas from Shankar Netralaya, Chennai, Dr. Rathinam Sivakumar from Aravind Eye Care System, Madurai, Dr. Vishali Gupta from Advanced Eye Care Center, Chandigarh, Dr. Kalpana Babumurthy from Prabha Eye Clinic and Research Center, Bangalore, and Dr. Somavya Basu from L.V. Prasad, Hyderabad, Dr. Salil Mehta from Leelavati Hospital, Mumbai. So we have esteemed panelists to discuss the presentations, and also I welcome all the speakers, the audience for the active involvement in this program, and I request the audience to write the comments in the chat box. Since the program is tightly packed, we will answer to the queries. This will be answered by the presenters and the moderators. Without much delay, we will move on to the program. I invite our first speaker, Dr. Balamurugan from Aravind Eye Care System, Pondicherry. He will be talking to us on unlocking insights, a clinical dive into uveitis. Over to Dr. Bala.
Good evening, everyone. Good evening. Just to say that apart from what Dr. Padma said, that the way we have stacked the webinar with all our star speakers is that the talk itself is for 8 minutes, followed by a 2-minute discussion, and each speaker will be followed by 2 from the panel who will be discussing their talk. So over to you, Bala.
Good evening, one and all. Is my
slide visible? Is my voice audible?
Yes.
At the outset, I would like to thank ARC and Uveitis Society of India for giving me this wonderful topic, Unlocking the Insights, a clinical dive into uveitis. It's an overall perspective, what the clinician needs to know before actually handling a case of uveitis. The most important thing whenever we start seeing a patient of uveitis is to listen to a patient, because most of the time they are telling us the diagnosis. And in a busy clinic, this is one important art which is easily overlooked, and the basics should never be forgotten, as William Osler had said. This was a wonderful book written by a team, clinical workup in uveitis by my teacher, Dr. Ratnam, where 75% of the diagnosis can be obviously made from a detailed history taking and through a systemic examination. So history taking is a cornerstone in the management of any case of uveitis. The rules in uveitis practice, meticulous history taking is a prerequisite, not only for correct diagnosis and for correct treatment. And don't forget the rule number 1, because the rule number 2 is nothing. Again, go back to the meticulous history taking. So we all know what all systems to cover up. But apart from the history, the face saver history which I face in my practice is some of the overlooked histories like immunization, recent history of travel or trauma, and this history of prior hospitalization by any reason, either due to COVID or prolonged hospitalization, may give us additional information. The patient may be hesitant to give us all the information. Once we ask this, any prior history of hospitalization or treatment, we need to meticulously document in our records. So let me illustrate this. This was a 42-year-old lady who presented with pain redness and best corrected vision of 636. Obviously, you see a keratouveitis of anterior presentation. The resident immediately started with topical steroid after ordering the investigation. This was one history which was easily overlooked. That is a native treatment with the vegetable matter. After 3 days, when the patient presented, there was a fulminant keratitis. Obviously, we did an AC tab and sent for culture, improved it as Aspergillus fumigatus. So the moral of the story is detailed history taking, which are easily overlooked, are very, very super important before we handle any case of uveitis. Small things makes perfection, but perfection is seldom a small thing. So we all know that there is a standardized uveitis nomenclature, grading of cells, grading of flare. However, we need to be crystal clear that we need to assess the intrinsic attributes of the cells and flare, and we are going to treat the cells and not the flare. Okay, the qualitative attributes of cells and flare, what does it mean? It not only includes the number, size, color, consistency, focus on the mobility of the cells. Sometimes the pseudo exfoliation or the pigment dispersion could masquerade. It has both an intrinsic and an extrinsic mobility, and also the other inflammatory indices, whether the cells are correlating with the magnitude of congestion or other inflammatory parameters. So before deciding how to treat, we need to meticulously categorize the inflammation. Where does it stand in the eye, the anatomical localization, look at the systemic association, and following the reports, we need to assess the response to treatment, pattern of recurrence, and specific diagnosis of treatment. In my presentation, I will handle each one of them separately. So most of the seniors, like Dr. J.B. Sir, Dr. Ratnam, I consider them as Michelangelo, because they carve out, in those days, 20 years back, before all this multimodal imaging were there, they carved out beautiful stone from a big block, like the beautiful masterpiece you see here. However, now this casting technology has come. We can use a lot of imaging, PCR, and our job using the investigatory parameters along with the clinical picture becomes much easier. Being a clinician of the current era, we need to not only be like a Michelangelo, as well as be good at correlating the imaging with the correct presentation, what we see in our patient. The first thing, as I said, is evaluate meticulously the anatomical localization. See whether the uveitis is anterior or there is a spillover into intermediate posterior or panuveitis, and then come to a reasonable consensus whether it is inflammatory or infectious. The severity of inflammation needs to be clearly assessed, and the secret of uveitis treatment is titration. So is the magnitude, so should be the severity of the treatment. So we all know that the razor blade cannot be used to cut a tree, and everything has got a limitation. So to give an analogy, for an NS4 cataract, we cannot use an NS1 sitting. So when there is a severe inflammation of 4 plus cells, we will be using more of frequency of the steroids, or a hypopion, you will be using hourly steroids. Whereas for a much less severe uveitis like 1 plus, the frequency should be much lesser. The ideal strategy should be based on what you see in front of you from the response to treatment. So as you see in this picture, there is a fibrin membrane or a trace hypopion. We need to be very, very aggressive in starting with higher frequency of steroids. The systemic associations are also super important. For example, in JA, when there is a systemic association proven, we need to be very slow in tapering and a maintenance dose. Whereas in HLA-B27, based on the response to inflammation, best sets a careful titration along with investigative parameters are important. The coexisting contraindication is also important when we are using the steroids. For example, when there is an advanced glaucoma, we need to be careful with the usage of steroids, or you can think of supplementing with non-steroidals and lubricants. Fungal scleritis or uveitis, careful in using this weapon of steroids. The response to treatment is very important. So assess whether the treatment response is optimal or suboptimal or superoptimal. So when it is suboptimal, the thing that comes to my mind is think in terms of BESEDs or an aggressive inflammation, or there is a superoptimal, think about sarcoidosis. So the basic thing for treating an uveitis is the skill set of the sprinter and marathoner are entirely different. For an acute uveitis, short-acting steroids are preferred, whereas in a chronic uveitis, long-acting steroids are important. When you do ULTA, for an acute uveitis, you give a long-acting or a short-acting steroids. For a chronic uveitis, it is considered as a mistake number 1 published by the American Academy of Ophthalmology. So those of you who are interested can go type that and you will get it. So during down taper of chronic uveitis, drug-free period causes a trigger for a reactivation of the inflammation. The pattern of recurrence is also important. So sometimes we need to give a maintenance dose below which the inflammation flares up. For example, in recurrent viral uveitis, we will also be adding specific antivirals. The choice of topical steroid is also important. Pred versus Dexa versus diflupred. We all know that diflupred is more potent, more aggressive, and a lesser frequency might be preferred. So set your priorities right. Reach the specific diagnosis. Not all uveitis are the same. For example, when you suspect lepto unproven, we need to think in terms of giving doxycycline or anti-ansense. In case of leprosy or syphilis, we need to give specific syphilis treatment. Unless we give the specific treatment, uveitis keep on bouncing, and don't blame the uveitis for its acute behavior. As you see in this case, this patient was referred to be to start on immunosuppressive for recurrent uveitis. Detailed history taking showed that the patient is using zoledronic acid for an osteoporosis. So we all know that it can cause a fibrinous recurrent uveitis. Stopping this drug causes total stoppage of the recurrence. So had I started on this patient on immunosuppressive, would have been a grave medical legal error. So we need to be very, very careful and evaluating the patient as a whole. The immune status of the patient is also important because this is one area which is commonly overlooked. Assess the general appearance of the patient, or is the patient likely to be harboring tuberculosis or HIV? Be aware of the paradoxical reactions. How do I suspect in my practice? Whenever the ESR is more than 100, before branding it as autoimmune uveitis, suspect an immunosuppressant, and the most common one is a HIV. So the tricks in uveitis, I'll end with another 2 slides. Hansen seldom presents as posterior pan uveitis because it prefers the cooler structures. Leptospira besides is mostly non-granulomatous. It seldom takes a granulomatous presentation because the type of KP's qualification is also important, which is easily overlooked. All granulomatous uveitis can initially start as non-granulomatous. So uveitis is like mathematics. If you understand there is in a Fuchs uveitis, there will not be any posterior cyanic A, no peripheral anterior cyanic A in posterior classman. Whenever in an uneven full cataract surgery, there is a brisk flare-up, ask for a history of prodrome of viral, and the specific treatment will help in preventing the recurrence. So we all know posterior cyanic is not there. how to suspect fugues, because a subtle stellate KP is very easily overlooked. Whenever a patient of uveitis, there is no posterior synechia, I zoom the lens and look for superior inferior stellate appearance of KPs. So from reverse, we should pick up the fugues uveitis, because unless you pick it up, you will be bombarding with steroids immunosuppressive, which is not going to be useful in fugues uveitis. Thank you so much. I end my talk with this.
Thank you, Dr. Bala, for the excellent presentation on unlocking insights and good clinical dive into uveitis. And thanks for emphasizing the meticulous approach in uveitis. I invite Dr. Biswas to discuss this presentation from his expertise. Over to sir.
I just, when I see a patient, I ask one thing, is it infectious or non-infectious? This is a very simple question I wanted to answer before I ask myself, is it infectious or non-infectious? Because there is a paradigm shift in the treatment of infectious versus non-infectious. For example, if you are seeing an pan-uveitis, actually B27 pan-uveitis, versus endogenous endophthalmitis, you will be making a grave mistake by doing the patient on topical and systemic steroid and delaying the diagnosis without doing a vitrectomy or a vitreous aspirate. This is one of the mistakes I don't want to make. Second thing, I wanted to see the uveitis first time if I see in the children with the hypopyon or without synechia, I will rule out the muscular syndrome. And also in the uveitis in the elderly, if I see first time, like over 60 years of age, I will try to rule out infection as well as malignancy, then autoimmune disease. This is the first thing I would look into it. And we give a lot of importance to the patient's files carrying it. Even however big it is, I just go through it and take my time showing to all the case sheets which are recording, because the patients might have been toxo and somebody giving it the steroid and injectable steroid and got into the acute retinal necrosis type of picture. These are the few things I wanted to do. In short, I just wanted to mention that.
Thank you, sir. Thank you so much for your.
Thank you. Thank you, sir. Thank you, Dr. Bala. Next, we invite the next speaker, Dr. Mohit Dogra from Advanced Eye Center, PGI, Chandigarh. He'll be talking to us on seeing the bigger picture, systemic evaluations in uveitis. Over to Dr. Mohit.
Thank you, ma'am. Thank you for the opportunity. And thank you to ARC and the Uveitis Society for giving me this topic. Are my slides visible and am I audible?
Yes, sir.
Yeah, thank you. So I'm going to be speaking on, just to ensure that I'm going to stick to time, I'm going to actually time myself. And actually, here we go. Dr. Balamurugan is a tough act to follow at the best of days. And so I'm going to try and do whatever I can. And the topic given to me is seeing the bigger picture, systemic evaluation in uveitis. And I'd say that, so systemic evaluation in uveitis should include routine systemic workup, specific exams guided by the anatomic classification of uveitis, that Dr. Balamurugan alluded to very nicely, the clinical findings, which he touched upon with certain, caveats, which were, excellent, I think, for clinical diagnosis. And Dr. Biswas actually spoke about the importance of having a mental picture when you see a patient, when you take a good history, whether you're suspecting an infection, whether you're basically suspecting non-infectious or a masquerade. And then, your history also has to be tapered towards, yes, what you might think might be the cause or what the treatment the patient might have had. And after you have a better understanding of all of these things, then you try and taper or kind of modify your systemic evaluation that you would do of these patients, and we'll see how. So this is not going to be very exhaustive, but I'm just going to include the 3 or 4 points, which I think, so ophthalmology is medicine. I think a lot of people tend to forget that. I think it's important to, keep in mind that we're not just confined to the eye. We are physicians. We're all MBBS, and then we do our postgraduate degrees in super specialization. So we must know, and we must go back to our knowledge of general physical examination and, just taking a look at the patient, and not in general, not haphazardly. At least these 4 things. And why I'm saying these systemic evaluation features in almost all patients, not all, is because if it's a toxoplasma or if it's a Fuchs uveitis or a CMV retinitis, well, then those are typically clinical diagnoses, and you might not want to try and go through all of these. But for the most of the other ones, you'd actually want to ask oral or genital ulcers, their frequency, their site, their duration, whether they are aphthous, whether they are recurrent, whether they are related to dentures, whether they keep happening after food or whatever. Skin lesions, I think, very, very important. I think all integumentary findings, skin, nails, mucosa, are very important. Skin is easy, and you have to ask leading questions, especially up north where we come from. Winter months, people who might be decked from the neck all the way down to their feet. Even they might have gloves on, so you'll not be able to even make out a very kind of obvious skin lesions. But you must ask the size, the location, the color, and the type, because all of them will try and push you in a particular direction. Certain things are pathognomonic, as we will see in the next slide. You must ask for joint pains or joint aches or morning stiffness or plantar fasciitis, because low back pain, neck stiffness, certain joints will be carry a diagnostic value given the right clinical setting. So I think these are very, very important. And the 4th is fever. Fever/weight loss/malaise, the typical triad of the constitutional symptoms that we used to read about. And fever in particular, whether it was just one-off, preceding the illness, whether the patient has episodic fever, if there's a particular pattern, let's say evening rise or whatever, is associated with rigors and chills. So I think all of these are important. And with that, you're actually going to come down to systemic, evaluation and certain ecological clues that these evaluations might give you. So oral or genital ulcers, if you're able to either elicit a history or able to see them yourself, you would want to strongly look at Behçet's disease and syphilis. There could be others, but these 2 are very important. Neck stiffness, low back pain. Again, given the correct clinical scenario, I think spondyloarthropathies, of which HLA-B27, one of the commonest types of uveitis in general, and arguably the commonest anterior uveitis that you see. If you get neck stiffness, low back pain, that's something that is very, 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 very suggestive. Skin lesions, Behçet's disease, sarcoidosis, lupus pernio on the nose, syphilis, psoriasis, Lyme's disease. Each one of them have separate ones, typical ones. If you have a rash involving the palm and the soles, I think that's almost pathognomonic of either syphilis or Coxsackie virus. Both of them can cause uveitis. Syphilis, of course, a lot more commoner than the Coxsackie virus. The Coxsackie causes the hand, foot, mouth disease, and typically a lot of these, rashes will kind of stay away from the palms and the soles. But if the palm and soles are involved, I think it is almost pathognomonic. You can pinpoint the diagnosis. A nose and pinna swelling, which pretty much points towards involvement of the cartilage, either destruction or inflammation. Depending on if it's destruction, then it points towards GPA/leprosy. If it's just inflammation, extremely tender, tip of the nose or the pinna, and you can almost make a diagnosis of relapsing polychondritis just going like that. And the patient really wincing in pain because it's primarily an inflammation of the cartilage. If there is any history of systemic surgery, any indwelling catheters, patient might be not having any of these, might just have an IV infusion history, then I think endogenous endophthalmitis is something that should be kept in mind. Even if the patient is absolutely hale and hearty and fit and walking into your clinic and not being brought in, by his relatives on a wheelchair or on a stretcher, because IV infusion, for whatever reason in our setup, a contaminated infusion can cause that. Chronic cough with other, pulmonary symptoms, sarcoid, pulmonary TB in our setup. And mind you, pulmonary TB, but you can have TB in the eye without having pulmonary involvement. So please don't have the impression that if you don't have chest symptoms, it cannot be TB. Of course, if you have CNS symptoms, and those could be up symptoms or down symptoms, so epilepsy, drowsiness, myoclonic jerks or whatever. So it could be TB involving the brain. It could also be Behçet's, Takayasu arthritis. You can have altered sensorium because it generally tends to affect the arch of aorta, which will also, supply the CNS. Typical patients might of lymphoma, herpes simplex virus 1, so ARN patients or certain other patients with anterior uveitis or other afflictions of the anterior segment and the ocular adnexa by HSV can have encephalitis and might have issues. SSPE, myoclonic jerks, poor scholastic performance, absence of good immunization kind of history or chart, all of them in a particular child with typical findings could point towards these things. Now, with that, I'd actually like to discuss 4 cases, of which one is, will actually drive home the point of how systemic evaluation tapered out down to after your clinical exam can help. This was a 34-year-old male. He was in fact a doctor. He had a paracentral scotoma in the right eye for 2 weeks, acute onset, progressive, had a ring right scotoma, had no flashes, was diagnosed outside as azure, was started on oral steroids. However, he said that his symptoms worsened. He was also a diabetic on top to boot for the past 5 years. He came to PGI because on oral steroids, having been made a diagnosis of azure, he actually worsened over 2 weeks. That's what he had when he came to us. 6/9 parts, no AC vitreous cells. The fundus picture was unremarkable. However, the autofluorescence shows, that typical appearance. The left eye was normal. The right eye, the OCT actually shows, and the bottom one with the kind of red circle actually shows the loss of the outer retinal layers, which is highly suggestive of azure/outer retinal pathology. But if you have an azure-like pathology like you have there, and it's getting worse on steroids, what you want to try and do, and again, the visual field to support it, you want to try and take a look, and you want to try and rule out syphilis. We asked for a systemic history. This patient said he has some issues in the mouth. He had oral candidiasis, we got a VDRL TPH that was positive. He was HIV positive. He did not know that. He had CD4 counts was 174, and the oral steroids were actually worsening this condition. He had a penile ulcer 1 year back, which is all on his own. He was actually divorced and had multiple sexual partners as a risk factor as well. After neurological, testing and getting IV ceftriaxone, this is the resolution you can see. The bottom is the presentation, and the top is it's almost gone. The symptoms are gone. The autofluorescence is gone, and the OCT as near reversed. So it looked like azure, it felt like azure, but the clinical exam tilted the diagnosis and almost made us very sure that this is immunosuppression, and this patient had, that. So tailored clinical systemic evaluation is actually what you want. This patient, occlusive retinal vasculitis, both artery and vein, actually had an oral ulcer, had these skin lesions, went on to actually have Behçet's disease. So these things help with typical oral ulcers and that involvement. This lady had a combined central retinal artery and vein occlusion, came with no light perception, had these findings all over the face, had the discoid rash on the malar rash, both sides, also had a strawberry tongue, had SLE, was febrile, low hemoglobin. This patient, again, had occlusive retinal vasculitis, had a branch retinal arterial occlusion, combined occlusion, was a nursing student, was the father of a nursing student, and actually that's what he had maculopapular rash on the tongue, and this was again secondary syphilis. And one last thing before I end, this patient had necrotizing scleritis, and something like a surgery-induced scleral necrosis was thought of. However, this patient had a typical deformity of the nose, and the CT scan actually showed eroded bony spectrum, and this actually turned out to be GPA. So certain clinical, typical targeted investigations based on your history, your infectious, non-infectious kind of naming and meshing, and then if you do a targeted systemic exam of integumentary findings, nails, I think it'll help you, narrow down the diagnosis, and in some cases actually clinch the diagnosis. Thank you.
Thank you, Dr. Mohit, for emphasizing the importance of systemic evaluations in uveitis with good case examples. I invite Dr. Ratinam to share her expertise of importance of systemic evaluations in uveitis. Over to you, ma'am.
It's a very good presentation, doctor. It was a fantastic presentation. I always say that it is extremely important to take history and absolute clinical examination. Unless let us believe that there is something behind and which we are not seeing. And especially in your case, when it was not responding to steroid, you go back again and start everything from the beginning. And all 4 cases were fantastic. And it is not the quantity of cases we see. Each case should be given quality time and quality attention. Then many of our patients will be benefited. Both morbidity and mortality can be reduced. There was one patient, routinely they suspected because of high positive MAN2, they did a CT scan, but it was Takaiso arteritis with scleritis. So sometimes it will be very surprising for us to see such a big diagnosis. So I congratulate the presenter for a very good cases. Thank you. Thank you for the opportunity, Padma.
Thank you, ma'am. Thank you, ma'am. Thanks for the valuable tips.
So, Padma, can we go on to the next presentation?
Please, yeah, please go ahead.
Thank you. So that was really top 2 exciting presentations and quite a few more to come with a lot of stars. Coming to presentation 3. So we have seen what are the clinical insights of uveitis. We've also seen the bigger picture in terms of systemic evaluation. So what investigation should we order? Should we just do so many systemic investigations? What lab investigation should we order? So Dr. Amitabh Kumar is going to take us through navigating lab investigations and ordering the essentials based on the clinical drive, clinical history and details of the patient. So over to you, Dr. Amitabh. Dr. Amitabh is a senior uveitis specialist. He did his training at Shankar Nethralaya and is now practicing in Calcutta.
Good evening. I would like to thank ARC, AIOS, and USI for this opportunity. I have no financial interest in my presentation. So investigations in uveitis should be judicious. And why would we investigate a case of uveitis? Because we want to differentiate between an infectious and a non-infectious uveitis to identify specific uveitic entities for diagnosis, prognosis, and for mapping out our treatment. That wouldn't mean we go for a fishing expedition. So there could be 2 approaches, a totally empirical approach or a totally lab-dependent approach. But I think a tailored laboratory investigation is the best bet. Having said that, there are certain entities where you do not need to do any tests, like a Fuchs, heterochromic iritis cyclitis, a traumatic uveitis, or an unequivocal case of VKH and SO. There are certain basic investigations which would be required for most patients who are to be put on potentially toxic systemic medications, and that would include routine blood, urine, stool, and liver functions and renal functions wherever indicated. So after a detailed history and a comprehensive ophthalmological examination, we would come to a working clinical diagnosis. Then we would figure out the differentials, order only relevant lab investigations first. Extensive investigations would be required if there's a diagnostic dilemma or if the patient is refractory to treatment. So let's see a few examples. A young male, an angry-looking eye, you can see a hypopyon. So this was an acute unilateral non-granulomatous anterior uveitis. Of course, our approach would be a very important history taking to know whether this was the first episode or has he had recurrences or what has been his response to the previous treatment, a few systemic history. To start with, the first investigation which I would do is an HLA-B27. On the other hand, you can see mutton fat curatic precipitates, so a granulomatous anterior uveitis. So how to go about it? So we would rivet our attention to basically 2 etiologies to start with, for TB and sarcoid, and therefore we would do investigations towards these. We would do a mantle test, a quantiferon TB gold test, a serum ACE, and image the patient. This was a young patient with pigmented curatic precipitates all over the endothelium, a steamy cornea, a raised intraocular pressure. So our working clinical diagnosis would be a viral anterior uveitis. And how would we diagnose? We would have to tap the patient and send the aqueous sample for PCR for viruses. And this patient tested positive for HSV1. This was a 25-year-old lady who came with complaints of defective vision and floaters, and you can see vitreous cells. And on indirect ophthalmoscopy, vitreous snowballs. So obviously, this is an intermediate uveitis. Again, we would want to look into TB, sarcoid, probably syphilis. In case there is a diagnostic dilemma, then we would tap the patient and send the intraocular fluid sample for PCR analysis. Whenever we see a retinitis, it is almost always infective vis-a-vis choroid, which is more often than not autoimmune. So you see this patient, a 34-year-old female who came with complaints of defective vision and floaters, and you can see these necrotic lesions in the periphery. Of course, this is an acute retinal necrosis. So what do we do now? We would want to assess the immune status of the patient, do a CD4 count, an ELISA HIV, and also do a PCR to find out the virus. She tested positive for VZV. A headlight in the fog, another retinitis. So this is a clinical diagnosis. This is a toxoplasma retinochoroiditis. So probably the only test we would do here is an ELISA toxoplasma. A 27-year-old male came to us, a railway engineer with a history of defective vision for the last 1 week. And you can see these yellow lesions, probably retinitis, and some hard exudates at the macula, a neuroretinitis kind of a picture. So we need to rule out infectious etiologies first. and he tested positive for IgG and IgM for toxoplasma. So he was treated with antitoxo and steroids, and he resolved over a period of 3 months. Another retinitis with arteriolitis, a 40-year-old male. So this again looked like a toxoplasma, but his ELISA toxoplasma was negative. So we might have to do PCR when there are atypical cases, but unfortunately, his PCR from the aqueous sample also tested negative, but he tested positive for IgG in the aqueous sample. So again, he was treated with antitoxoplasma antibiotics and oral steroids, and the lesions resolved. So an immunodeficient patient who had a diffuse multifocal retinitis lesions, a diagnostic dilemma, again underwent a PCR, and he tested positive for toxoplasma. So when did we do an ELISA HIV? Whenever we see a necrotizing retinitis, multiple cotton wool spots, or a herpes zoster ophthalmicus in a young patient, we would do an ELISA HIV. So this was a 34-year-old male who came with complaints of decreased vision and floaters, and you can see a lot of vitritis, hyperemic disc, pre-retinal exudates, placoid lesion, and the first thing which should strike us is ocular syphilis, and indeed he tested positive for VDRL and TPHA. Now, ocular syphilis is a big mimicker, and when we see a case like this, we would always do a treponemal test and a non-treponemal test. A retinal vasculitis could involve either the arterioles or the venules. So any systemic vasculitis or a viral retinitis would cause an arteriolitis, whereas TB, sarcoid, Behçet's, eels will cause phlebitis. And there's a whole list of investigations, but would we be doing all tests for all patients? Obviously not. So let's see a few examples. A young patient with a phlebitis, neovascularization, we must think about tuberculosis. He tested positive for MAN2 and quantiferon and had lymphadenopathy on HRCT. He was treated with ATT and oral steroids, and the lesions resolved. So a word of caution, TB ELISA should not be done from serum because of it's of very little diagnostic value because of a high prevalence of systemic TB in our part of the world. Another vasculitis where you see skip sheathing, probably sarcoid, had raised serum ACE and hyalolymphadenopathy. So when would we order serum ACEs? All cases of granulomatous uveitis, intermediate uveitis, and choroidal nodules. But patients on systemic steroids may have a false negative value, and a normal ACE level does not exclude the disease. So that's when we will have to rely on other investigations like imaging the patient or a tissue diagnosis after a biopsy showing a non-caseating granuloma. A young lady with a vasculitis and a butterfly rash tested positive for anti-dsDNA, so this was an SLE. This was a 66-year-old male who came with complaints of decreased vision, and you can see here a choroidal nodule. So our differentials were TB, sarcoid, and metastasis. So we focused on these three entities. He had a raised serum ESR and a raised serum ACE. All the other tests were normal. So he was treated with steroids, and he resolved over a period of 4 weeks. A serpiginoid choroidopathy, obviously we would rule out tuberculosis. This was a 55-year-old man with a bilateral hypopyon, a relatively quiet eye with so much of hypopyon. So he had no history of uveitis. So we did think about masquerade, and his blood counts showed a CML. So another 52-year-old male who had undergone a cataract surgery. He had no previous history of uveitis, was on steroids for chronic postoperative uveitis. So obviously we would not be thinking about a TB or a sarcoid or an autoimmune uveitis in this patient. We should rule out an infectious etiology, and he tested positive for P. acnes. So to wrap up, if there's a non-granulomatous interior uveitis, we would investigate for HLA-B27, ANA, ESR, or granulomatous interior uveitis tests for TB and sarcoid. An acute retinal necrosis, CD4 counts, ELISA HIV, and a PCR from the aqueous or the vitreous tab. GHPC, all tests for tuberculosis. So a history and detailed examination, we come to a working clinical diagnosis. We do tailored laboratory investigations first, would need extensive investigations in case there's a diagnostic dilemma or if the patient is not responding to your treatment. Thank you for a patient here.
Thank you very much, Amitabh. I think that was an amazing presentation because you really, in a very short time, briefly captured the essence of what we should be investigating and looking for. Just for the sake of the audience, SO that Amitabh had mentioned means sympathetic ophthalmia. And one quick question before I ask our panelist is, Amitabh, in the case that you presented, again for clarification, the one with intermediate uveitis. So you said that you would also do PCR. So just to check with you, what would you do PCR for?
So basically TB, and if we have a doubt where where the other investigations are not really taking you anywhere,
Okay.
anyways, you will be treating them with steroids. But in case there is a diagnostic dilemma, a PCR, say a PCR for MTB, that will help you in case it comes positive, then probably you will put the patient on ETT as well, along with steroids.
All right, excellent. So with that, I invite our panelist for your talk, Dr. Kalpana Babamurthy. As you know that she's a senior leading specialist in uveitis, also the president of the Uveitis Society of India. So Kalpana, over to you for your sound bites on navigating lab investigations.
Thank you, Dr. Somshila and Dr. Padma. Firstly, I would like to congratulate Dr. Amitabh for such a very descriptive talk on lab investigations, actually. So my 2 cents will be just adding on to your talk. And the most important part is, I think we should have a professional diagnosis based on the history, age, and the pattern of uveitis which we are seeing, along with the geographic area the patient is coming from, and then plan your investigations accordingly. If I have to add, then probably I will just add a few investigations which I would do in all my patients, which is your complete hemogram with peripheral blood smear, because this can give us a lot of clue, especially age when we are dealing with younger kids, as well as in granulomatous diseases. Sometimes you could see your lymphocyte counts drop. Sometimes you can pick up an accidental HIV with just your counts, which are low, and then you look for immune suppression that way. The other thing is blood sugars. Many times we miss this, and we've seen a lot of patients with hypopure uveitis, and you just get their blood sugars done, and the blood sugars are very high. So I think random blood sugar, 3 months average, your HbA1c levels, your basic liver enzymes, SGOT, SGPT, and serum creatinine, along with your urine routine, I would probably do in all my patients with uveitis. Apart from that, I think Amitabh has covered almost everything, so I wouldn't want to add anything more. But the essence is to plan your investigations based on whatever the earlier speakers have reiterated so much, that history, age, geography, and the pattern of uveitis makes a huge role in planning your investigations.
Thank you, Kalpana. Thank you once again, Amitabh. It's again my pleasure to invite the next speaker. We'll move on in because although this investigations is a very interesting topic, but we have many more interesting topics coming up. The next speaker is Dr. Sai Bhakti, and she's going to talk about deciphering uveitis imaging. So visualizing the complexity, and she's going to help us decipher uveitis imaging. Sai Bhakti, all yours. I'm very happy to see you, Sai, present at this forum.
Thank you, ma'am. Happy to see you too. And so I'll just present my topic, which is visualizing complexity and deciphering uveitis imaging. Just a second, yeah. So the role of imaging in uveitis is we use it for diagnosis, where we see the pattern recognition. We try to understand the level of the inflammation and also to assess the inflammatory signs. It's also used for the management of lesions, to understand the response to treatment, where we measure the lesions, and also we target our endpoint, which are also the surrogate markers. Thirdly, we use these imaging techniques to document for objective assessment and for research purposes, and also in the day of medico-legal awareness. We have multiple imaging modalities for our uveitis patients, but today I'm going to focus only on the posterior segment imaging modalities. For that, I'll start with the fundus photography. It is used to grade the vitreous haze and to document the lesions, whether the posterior pore or the periphery. But today we have the wide field photography, where we can see the vitreous haze, we can understand the extent of lesions, assess the peripheral activity, and also document and assess our lesions on follow-ups. We can never overstate the importance of peripheral retinal examination and documentation of our lesions, which again helps us assess our treatment response, especially when we start primary empirical treatment. We can also use our imaging, the photographic imaging, non-invasively to assess the retinal and choroidal vasculature using the red and green filters. Next, we come to multicolor imaging, where we use the blue reflectance, the green reflectance, or the infrared reflectance to understand the depth of the lesions. For example, this is a Mute's case where we can see that the lesions are in the outer retina. Hence, the lesions are best picked up on the infrared image. This is one of the favorite imaging techniques of the uveitis specialists when we have outer retinal or choriocapillaris kind of lesions. This is the fundus autofluorescence, which diagnoses the hyperreflective, which diagnoses the diseased or the dying retinal pigment epithelium cells where there is increased lipofuscin content. So here I'm showing the stages of a serpiginous like choroiditis, how initially the lesion is very hyper autofluorescent, and as the lesion heals, there is dead retinal pigment epithelium, which causes this hypo autofluorescence. But we also use this technique to look for paradoxical worsening, where we may see an increase in size of lesions or an increase in number of the lesions. We also use it for white dot syndromes, where the lesions are between the retina and choroid, or that is the outer retina and the inner choroid, in cases of Mute's and Azure, and we look for active lesions. This is a case very similar to the one shown by Dr. Dogra, where there is the outer retinitis lesion, and very clearly seen on this OCT image. And this patient was diagnosed with syphilitic posterior placoid chorioretinitis, which is the most common syphilis presentation in an immunocompromised patient. What I want to emphasize here is that autofluorescence is a non-invasive tool that can be used to assess the inflammatory diseases of the outer retina and choriocapillaries. Fundus autofluorescence is cheaper than the OCT, and it is non-invasive when compared to an angiography. Hence, this is a ready-to-use tool to assess treatment response. Coming to optical coherence tomography, the OCT, these are the macular OCT scans where we can see large vitreoretinal deposits on the vitreoretinal interface deposits. And this was a case of toxoplasma retinitis. So this brings me to the point that whenever we have large roundish posterior hyaloid phase precipitates, we must suspect an infective etiology. The macular scan may not show a lesion, but this gives us a clue, as in this case, there is a nasal toxoplasma retinitis, and this case has an inferior CMV retinitis. Toxoplasma retinitis is the most common infective posterior retinitis that is seen, posterior uveitis, and hence there are multiple signs that have been described in this. Viral retinitis, on the other hand, is commonly associated with the vasculitis, and hence it can have intraretinal edema and subretinal fluid. The below picture shows a CMV granular form of retinitis, which does not have much vasculitis. So these lesions will just show only a necrotizing pattern without backshadowing. So when we have a full thickness necrotizing retinitis with underlying choroidal thickening and backshadowing, it may heal with total loss of tissue in cases of toxoplasma retinitis. Viral retinitis presents as a full thickness necrotizing retinitis without a significant choroidal thickening or any backshadowing. Rather, it may have intraretinal edema and hyperreflective vertical strips within the outer nuclear layer. And post-fever retinitis, which is another common posterior retinitis, it presents with macular edema. So these are the important points we need to remember, that necrotizing retinitis with backshadowing and choroidal edema, think of toxoplasma retinitis. When you have necrotizing retinitis with intraretinal edema and vasculitis, think of viral retinitis. And in cases of post-fever retinitis, apart from the history of a recent fever, when we have a macular edema, subtle to significant, we must think of a diagnosis of post-fever retinitis, because the treatment for all the three are different. Coming to fungal lesions, these are they initially start out to be very focal and localized lesions. So the first one is a candida endophthalmitis, which has been described with an inverted snowing cloud sign, where the retinitis has just an adjacent vitreous reflective dots, and the second one is an aspergillus endogenous endophthalmitis, whereas there is again a localized chorioretinal abscess. Coming to choroidal granulomas, TB choroidal granuloma can present with a choroidal elevation suggestive of the granulomatous lesion with the contact sign where the neurosensory retina is attached to the RPE with exudative material in the subretinal space and presence of subretinal fluid. On the other hand, a sarcoid granuloma may be very innocuous appearing on clinical examination, that is on the direct, or I mean the indirect ophthalmoscopic examination. But on the OCT, we can see such a large choroidal granuloma, which resolves nearly completely with immunosuppressive treatment. Next is the APMPP, or the acute posterior multifocal placoid pigment epitheliopathy, where we can see initially there is elevation and disruption and suppression of this photoreceptor junction, followed by increased RPE hyperreflectivity and focal areas of photoreceptor and RPE atrophy. It is important to make a diagnosis of these lesions because such patients are noted to have about 50% of these patients may be having some neurological involvement like cerebral vasculitis. Next is the invasive imaging of fundus fluorescein angiography. It is used to understand the activity of the vessels within the vessels, whether it's a diffuse vasculitis, a peripheral vasculitis, a capillaritis, capillary non-perfusion, neovascularization, and compensatory mechanisms like the collateral formation. We also use FFA on follow-up to understand the resolving vasculitis and reperfusion of vessels. This was a patient with idiopathic non-granulomatous anterior uveitis and recurrent intraretinal fluid. And this patient had a mildly hyperemic disc. It was only until the FFA was performed that we could understand that the patient was harboring so much of inflammation within and that she needed a prolonged immunosuppressive treatment. Hence, recurrent macular edema or recurrent anterior uveitis, one must perform a fundus fluorescein angiography to assess the extent of inflammatory activity. We also use fluorescein angiography to denote the CNP areas that can be targeted laser can be done to those areas to prevent the recurrence of neovascularization. Indocyanine green angiography is used to study the choroidal involvement or the pattern of the choroidal lesions that are not clearly seen on indirect examination, photographic evaluation, or even on the fluorescein angiography. The first is the retinitis. As we can see on the FFA, the lesion looks smaller, whereas in the ICG, we can see a much larger involvement on the within the choroidal space. And in cases with choriocapillaritis, the lesions on ICG appear much more than what we see clinically on direct examination and even on fluorescein angiography. A choroiditis lesion will appear initially hypo in the early phases and it becomes hyper in the late phases. This was a patient who had a history of granulomatous anterior uveitis that resolved, but her disc hyperemia and edema was persistent. The OCT showed peripapillary fluid, a peripapillary intraretinal fluid suggestive of chronic inflammatory edema, but the other retinal layers and the choroid apparently appeared normal. So the fluorescein angiography, here we can see that there is significant disc hyperfluorescence and a very few hyperfluorescent spots in the retina, very blurred spots. But it is the choroid that gave away the diagnosis of multiple choroiditis lesions that were there. So in patients with persistent disc edema, one must do an ICG to look for these multiple partial thickness choroidal granulomas. This is a typical VKH case. As we know, it has disc hyperfluorescence with pinpoint leaks and late pooling of the dye. And on OCT, we have the RPE undulations with subretinal fluid and hyperreflective dots in the inner choroid and photoreceptor layers associated with choroidal thickening. ICG is also used to identify CNVM in cases with chronic uveitis, where there is retinal pigment epithelial damage, and that can cause staining of the RPE. So as we can see here, the CNVM network is better identified on ICG. Next is the OCTA-scan, the optical coherence tomography angiography imaging, where the retinal ischemia, the retinal and choroidal neovascularization, and the flow, blockade effects of like the choroidal granuloma where we see flow void areas, these are all used to assess non-invasively and plan our treatment. OCTA has been used for cases with APMPP, and they have shown that there is reversal of flow following treatment. So this is another very useful non-invasive modality which can be used to see the follow-up of patients and assess treatment response. This is one case of multifocal retinitis that had resolved, and the fundus on examination looked pretty same in both the visits. The vision was also apparently the same, but the OCT through the macula showed that there was distortion of the ellipsoid zone and increase in subretinal hyperreflective material. And hence we suspected a CNVM, and so did the OCTA show that there was a branch vascular network that was present there. So this is my last pearl, that an OCTA can be done or should be done to detect any CNVM within the shrum material if we are having progressive outer retinal loss, even if there is no subretinal or intraretinal fluid. This can help halt the damage to the macular area. Nevertheless, we will always have to use multimodal imaging. This is a case of nodal posterior scleritis, where we can see that we have a choroidal elevation with subretinal fluid. We get some pinpoint spots here with these hypofluorescent folds of the retina, but it's the subtenon's fluid and the T sign that gives away the diagnosis. And these unifocal posterior scleritis patients respond very well to treatment. So just will wrap up quickly that fundus autofluorescence can be used as a non-invasive tool to assess inflammatory diseases of the outer retina and choriocapillaries. When we have larger vitreoretinal interface deposits, we must suspect an infectious etiology. Necrotizing retinitis with backshadowing and choroidal edema, think of toxoplasma retinitis. Necrotizing retinitis with intraretinal edema and concomitant vasculitis, think of viral retinitis. Post-fever retinitis is commonly associated with some subtle to significant macular edema. FFA should be done to identify inflammatory activity, the complete inflammatory activity of the eye in patients with recurrent macular edema or anterior uveitis. Similarly, ICGA should be done to identify the choroidal involvement of patients with persistent disc edema, and OCTA can be done to detect CNVM in cases of shrum with progressive outer retinal loss. Thanking everyone. This is the acknowledgement, and thank you USI and ARC.
Thank you so much, Sai. That was a really comprehensive talk. I think you covered just about all the imaging modalities. With that, it's my great pleasure to invite Professor Vishali Gupta. As all of you know her very well, and also probably know that she's the president of the IUSG. So, Dr. Gupta, if you can just add your comments and tips, learning tips to this presentation.
Thank you. Thank you so much, Sheila and Padma Malini. And thank you, Sai, for presenting a great talk. As we saw in her talk, there are lots and lots of imaging modalities. And in the era of multimodal imaging, we want to do everything for every patient. And when we talk to comprehensive ophthalmologists, everybody may not have access to all the gadgets that we talk about. So I think from the era of multimodal imaging, now we are moving on to minimal imaging criteria. And I'm very happy to say, like Sai showed those beautiful images of white dots, mutes, how to see the mutes from ampy and serpiginous. So I think this is now the time where we define what imaging modality is required in which case, so that we don't have to do everything for everybody. And hopefully IUSG will come up with this criteria in Singapore in November about the minimum imaging criteria for white dot syndromes. So the second point, which she brought out very importantly, is the use of imaging biomarker to look at the etiology. And she showed it beautifully how to look at the infections, how you can differentiate toxo from your post-fever and from retinitis. I think that is what our youngsters should learn. You look at the OCT, you look at the loss of ellipsoid zone, and you automatically think of syphilis. You look at photoreceptor zone, you look at photoreceptoritis, you think of mutes. So I think it's more important to learn about the practicality and utility of each of these imaging modality. And like we do tailored investigations in lab, we should do tailored imaging so that we do that focused imaging and get the answer. rather than getting everything and getting confused. That's it. Thank you.
Thank you, ma'am, for the valuable tips. Thank you so much for joining from US. Next, I invite Dr. Priyansha. She's a Uveitis specialist from Sadhguru Netra Shikishalaya, Chitrakoot. She'll be talking to us the important talk that is corticosteroids and weight, choosing widely and when. Over to Dr. Priyansha.
Ma'am, I'm pressing share screen, but
Yes,
nothing
your
is.
screen is visible and you're audible too.
So, good evening, everyone. Thank you for the opportunity. So, even in the age of biologicals, corticosteroids allow rapid control of ocular inflammation and prevent devastating sight-threatening complications of uveitis. So, the principles of treatment are determine the primary site of inflammation, assess
I can't
severity.
see the slide. I can't see the screen. Can you, all of you can see the screen? I am not able to see the screen.
No. Priyansha, you have to probably share the screen.
I'm trying to share the screen, ma'am. It's not getting shared.
Has the previous speaker stopped sharing?
Yeah, now it's coming.
Yeah. Now it's coming. Go to
Slideshow.
view slideshow.
Now?
Yeah.
Perfect.
So, since 1950s, steroids are being used for uveitis, and when used cautiously, they allow rapid control of ocular inflammation and prevent devastating sight-threatening complications. So the principles are determine primary site of inflammation, assess severity, rule out infections and masquerades, decide which medication to be used by which route, aim for rapid control of inflammation, hit hard, hit fast, limit side effects due to the medication itself. Remember, steroids by all routes accelerate cataract formation, tend to raise IOP, delay wound healing, and cause local or systemic immune suppression. One should be aware of the anatomic and the etiological classification of uveitis. Caveat: this 6-year-old boy was referred for right eye deviation of eye. We see BSK, relatively quiet eye, BSK, posterior cynic and cataract. The fundus examination shows just mild medial haze, but on fluorescein angiogram, we see extensive inflammation. So you should make judicious use of imaging modalities to assess severity. So various routes of administration of steroids can be categorized into regional, which circumvent systemic side effects. They are topical, subconjunctival, subtenon, orbital, intravitreal, and suprachoroidal, and systemic steroids, which are given through oral and intravenous route. And they give an advantage that if the need arises, they can be rapidly stopped. So topical steroids are the mainstay of mainstay in anterior segment inflammation. Examples are acute anterior uveitis in HLA-B27 positive or negative patients, post-op inflammation, spillover uveitis, spillover anterior uveitis and intermediate posterior and pan uveitis, traumatic anterior uveitis, infectious uveitis also, like viral under antiviral cover. They are typically used with cycloplegics. So for a very severe fibrinous uveitis, we use prednisolone acetate 1% drop, shake it well, use it intensively along with strong cycloplegic like atropinide drops. 4 times a day, difluprednate eye drops equals 8 times prednisolone acetate drops. But we avoid difluprednate because of its side effect profile. So this table depicts the penetration of prednisolone acetate into the anterior chamber, and that's why it's very effective. In contrast to prednisolone sodium phosphate, which does not penetrate very well and is better for ocular surface inflammations. So the precautions are shake the drops properly, especially the suspension, and instruct the patient that it's not a lubricant, beware of dendrites, rule out local infections like dacrocystitis, monitor IOP, avoid unsupervised use. Don't miss posterior segment evaluation. In post-op cases, recurrent anterior segment inflammation can be a sign of delayed onset endophthalmitis. Always follow up the patient closely. So regional steroid delivery circumvents systemic steroids. The typical indications are unilateral non-infectious moderate to severe uveitis with cystoid macular edema. They have very little systemic absorption. So they are a good option in systemic issues like uncontrolled diabetes, gastric ulcer, GIB, deranged liver tests, and obesity. They are also used as an adjunct. Ratina ma'am, can I? They are used as an adjunct for systemic IMT. They are best avoided in case of local infections, uncontrolled glaucoma, and scleral melting. So, periocular means around the eye. So, they're a good option in aphakic and complicated pseudophakia patients. They achieve high concentration RP and choroid, but drug absorption can be rather erratic. They are effective up to 8 weeks. Sometimes it's also been noted up to 3 months. The problem lies in the difficulty to retrieve the drug in case of any adverse reaction or infection. They cause severe local immune suppression and exacerbation of local infections. So there are 2 drugs and 2 techniques of periocular steroid. 2 drugs are triamcinolone acetonide, methylprednisolone acetate, and 2 techniques are subtenon injection and orbital floor, which have similar effectiveness. So best avoided in a case of scleral melt or toxoplasmosis. So complications. So complications are rare if given properly, but they can be devastating, like globe penetration, proptosis, central artery occlusion, optic nerve damage, and they can cause ptosis. And this is a case of infectious scleritis after subtenon injection. So coming to intravitreal steroids, so commonly available is triamcinolone acetonide, allows rapid delivery of potent steroid and lasts up to 4 to 6 weeks, and it has to be injected again and again. So they made this Ozurdex implant, which it's a biodegradable implant, which releases dexamethasone over a period of 6 months, with a peak occurring in 2 months. So the point trial suggested that the intravitreal treatment is superior to periocular approach in case of management of macular edema and non-infectious uveitis. So this is a picture of Ozurdex implant in situ. So the complication is that there can be anterior chamber migration of dexamethasone implant, and it's a rare complication. And risk factors are previous vitrectomy, aphakic eyes, PC opening, and lying in a prone position. So there is also other very long fluocinolone bands. One was in a higher dose, Retisert, which was sutured to the sclera. And now we have Utic and Iluvian, and they are non-biodegradable and they last up to 4 years. So the complications with intravitreal steroids are intravitreal floaters, vitreous hemorrhage, retinal detachment, and these are case reports of they are rare, but this can happen. Activation of CMV endothelitis, acute retinal necrosis, CMV infection, or even toxoplasmosis. Other problem can happen is sudden, like accidental injection into the crystalline lens and anterior migration of the implant. So systemic steroids are used where, even in a case of anterior uveitis, which is not responding to topical treatment, in bilateral or unilateral severe disease, patient has refused regional steroids, and where regional steroids are contraindicated. Even in infectious uveitis, after starting antibiotics, antiviral, antiparasitic drugs, oral steroid and non-immunosuppressive doses are used. So typical dosage is 1 to 2 milligram per kg per day of oral prednisone, no higher than 60 to 80 milligram per day, and gradually tapered over a period of 1 to 2 weeks. They are typically combined with with calcium supplements and proton pump inhibitors, and you have to maintain at a dosage less than 7.5 milligram per day. So a caveat is never combine systemic steroids with oral steroids because they increase the risk of gastric ulceration. For optic nerve and macular threatening disease, IV methylprednisolone pulse therapy can be given. Hospitalize the patient when you're giving intravenous steroids. Monitor vitals, look for cardiac arrhythmias. We always do a routine workup, CBC, LFT, KFT, urine routine, sugar, BP. We rule out septic foci, syphilis, TB in all cases, and take a physician clearance. So contraindications are systemic fungal infections, various infectious diseases, uncontrolled diabetes and hypertension, peptic ulcer disease, and congestive heart failure, avoiding patients with history of excessive alcohol consumption, psychiatric problem, osteoporosis, CSR. So there are myriad complications. They have, it's very difficult to take the medications for some patients, but I've seen they gain increase in appetite, stray, increase in blood sugars and BP, deranged, LFT, psychosis, menstrual problems, aseptic necrosis of the femur, herpes zoster reactivation of tuberculosis, and a very large axillary abscess in a patient. So the instructions which I give to the patient is to monitor sugar BP weekly, avoid spicy oily food, limit the sugar and salt, exercise, typically walking we tell them to do walking, avoid pregnancy. In case of fever, consult local physician. Do not stop suddenly after 15 days, and better to take medication in the care of a local physician. So we know that regional or systemic steroids can be taken, and 3 to 6 months of poison. So coming to cases, this was a case of a young lady who presented with blurred vision and headache, and you can see a hypopyon, and NCT was normal. Systemic history was non-contributory. On topicals only, she got better. The fundus fluorescein, we investigated the patient intensively. There was not much of posterior segment involvement. So in case of we are following up the patient, anterior segment inflammation, just topical steroids with cycloplegics will suffice. So this man came after COVID. He was a one-night patient and he presented with a loss of vision in left eye, and he was having a serious retinal detachment. And OCT shows RP undulation and fibrin. This FFA showed some stipple fluorescence, and ICG actually showed CSR. So I avoid steroids in this patient and just advise him head elevation and avoid stress. And just by doing nothing, the serious retinal detachment, it got better and vision improved. So steroids can seriously worsen CSR, and whereas there are the treatment of choice of inflammatory disorders, and so it should be avoided in where you are suspecting CSR. So this was a asymptomatic lady with small granulomatous KPs and no CME and synechiae. And so this is a Fuchs case, Fuchs uveitis case. So we should avoid steroids in Fuchs uveitis because they will accelerate the cataract formation, and if the glaucoma also, it will come sooner than later. This is a case of bilateral multiple serous retinal detachments. And these are all indicated. The clinical features are suggestive of both Koyanagi-Harada's disease. So this is a severe form of pan-uveitis. So they give intravenous steroids and followed by oral steroids and IMT, and you see the resolution of the detachments. And
time is getting up.
Yes. So this was a case of choroidal masses and serous retinal detachments, and it was having white spread meds. So you should be wary of masquerades also, neoplastic. This was a case of severe choroiditis edema, showing the imaging showing severe inflammation with a necrotic mantle. This was induced with the IV steroids in ATT and continued on oral steroid IMT and oral steroids, ATT and azathioprine. So in paradoxical worsening, what happens is that when you start ATT, along with this patient was started with oral steroid, there was a lot of increase in inflammation. So in paradoxical worsening also, you have to step up the steroids along with a continuation of the ATT. So in viral infections, avoid depot steroids and intravenous steroids. In viral infection, typically you have to give like acute antivirals followed by at least 3 to 5 days later steroids. So this is a case of syphilis where after starting antibiotics, increase in lesions. So there it was oral steroid was given and the lesion healed. So avoid oral steroid in a case of just oral steroid in case of toxoplasmosis. So the message is don't hurry to start oral steroid. Be sure what one is dealing with. Rule out infections and masquerades. And once you are sure you are dealing with uveitis, hit hard, hit fast, and don't use suboptimal doses. Pediatric cases, I think it's better to refer to a uveitis specialist. Always rule out pregnancy and ask the patient if she's feeding, and monitor the patient carefully for side effects and resolution of the inflammation. Thank you.
Thank you, Dr. Priyansha, for highlighting the complications and contraindications for corticosteroid therapy in uveitis. The discussant for your presentation is Dr. Salil Mehta from Lilavati High Hospital, Mumbai. Over to Dr. Salil.
Yeah, hi. Can you hear me? Sorry, for some reason my camera is just not coming on.
Yes, you're audible, Salil.
Yeah, okay. So Priyansha, it's a very lovely and a very, very detailed discussion. There are just a few points in your discussion and per se that I want to highlight. Number one is that numerous studies done by rheumatologists have always said that any dose less than 7.5 mg a day of corticosteroids is generally not associated with significant complications in the long term. So if you are able to control the patient on 7.5 or less, you really don't need to switch to any other form of immunosuppression. You can be quite comfortable and continue with that. The second thing is, which I think the next speaker is going to talk about, the big problem that I think all of us face is that general ophthalmologists per se tend to switch off steroids too early. And they always come back with a recurrence. So as you correctly said, you need to hit hard and you need to hit for the correct duration of time. For some reason, general ophthalmologists are very afraid of increase in IOP, cataract formation. And so they taper off probably patients too early. So if in general, I always try and make sure that you tell the patient, okay, IOP may rise, it will rise in about 1/3 to 1/4 of patients, but it may take some time. It may take 4 to 6 weeks if you are a steroid responder. Rarely earlier, I don't deny that. But don't worry about it. If you keep a good check, you can keep these patients even on topical steroids for a long time and systemic steroids for a long time without any untoward effects. The other problem is that we are always a little reluctant to start biologicals because we don't have any experience with them. So I always feel that if at all you feel that steroids are not enough, get a rheumat opinion as soon as possible or a physician opinion as soon as possible, so you can plan to switch the patient over to another immunosuppressant like mycophenolate mofetil or HCQS or methotrexate, or consider adalimumab or any of the variants of that. So otherwise, I think it was a lovely presentation and it should be mandatory listening for all PGs.
Thank you, Dr. Salil, for the valuable tips.
Thank you, sir.
Welcome.
Yeah. Thank you, Dr. Priyansha. With this, we'll move on to the next talk. The next talk is on practical guidelines in the management of immunomodulatory therapy by Dr. Amit Khosla. Dr. Amit Khosla is working in Gangaram's Hospital, New Delhi. Over to Dr. Hamid.
I think Amit is muted. I'm not able to hear.
Dr. Amit, you are not audible. Your slides are moving. Can you unmute yourself?
Dr. Amit, you need to unmute yourself and start your camera. We are not able to hear or see you.
Yeah, can you?
We can hear you now, Amit.
And
Yeah.
hear you. Amit, you can hear you.
Yeah. Okay. So immunosuppression, I thank ARC and the AOS and the USI for including me. As the previous speaker,
If you can share as full screen. Thank you.
if steroids had no side effects, I think we do need to replace them with any drug. They're the most potent immunosuppression. The message I want to give is that steroids are more potent, and do not think that the other drugs are going to control what steroids can do. And always we have a dilemma that whether it's infectious or non-infectious. Once you're sure it's non-infectious, you have to hit hard and you have to be aggressive. 30% of our total uveitis patients will turn chronic. That is, there's a breakdown of the blood aqueous barrier, blood retinal barrier, and there will be recurrence. So you need to reduce the side effect of steroids and mix up with another drug, which will help minimize the side effects. So what happens is that when you tend to taper steroids fast, you tend to develop complications of low-grade inflammation like macropathy, hypotonia, glaucoma, optic neuropathy, neovascularization, and cataract. So our aim in uveitis should be to aim for a 6x6 vision without cataract or glaucoma. If we aim that, yes, we will succeed in our endeavor. One of the articles which USI did in the lockdown period was this review article in IGO. This whole issue was on uveitis. So as Dr. Salil mentioned, if the steroid therapy you require for more than 3 months or more than 7.5 milligram, you will require an additional drug in addition to steroid. So at the beginning of the treatment, can I have an idea, will this patient at 3 months require immunosuppression? Because when you give steroid, you give high dose and taper, but in other immunomodulatory, you tend to start with a lower dose and then increase. If you are late at starting the drug, say at 3 months, the efficacy will come by 5th or 6th month. So in the beginning, you need to be clear that these patients will require more than 3 months. Those who start with the low vision, with the retinal choroidal macular involvement, recurrent relapsing disease, bilateral disease. And in children, almost 90% will require immunosuppression because you don't want to give them oral steroids. And there's a small group who are intolerant to steroid, who are steroid responding to get hypertension, diabetic, where you like to start things early and prevent uncontrolled diabetes. Those patients which require more than 3 months, everybody knows Behçet's, Wegener's, JIA, Serpiginous, symptoms and birdshot will require more than 3 months. So at the end of say 1 month, you can start the immunosuppression. So it works by the 3rd month. Here, these systemic diseases where immunomodulatory therapy and biologicals are established mode of treatment. If you have these patients, do consult your rheumatologist who may want to increase the immunotherapy. As I mentioned, when you start to taper the steroid and you tend to start the immunotherapy late, you end up with a period about 2 to 3 months when you have a recurrence of disease. Some people would add implantable steroid to control, but if you were to start at the right time, say at the end of 1 month, if you feel at the end of 1 month the patient still has active disease, has more than 30 milligrams steroid requirement as determined by the focus study, it's ideal to start immunotherapy early. But remember that immunotherapy is not as effective. The side trial showed us that the efficacy of these drugs, in association with the mild steroid dose, was only 60 to 70%. And steroid sparing was only in about 50%. And about 10 to 20% of patients became intolerant to drug because of toxicity. Remember these 3 drugs which we use commonly, azathioprine, methotrexate, and mycophenolate, are the commonest 3 drugs we use today for our patients. And if they do not respond, we shift to biologics. As mentioned, the local treatment can cause cataract glaucoma. Conventional immunosuppression is effective only in about 50%. The MUST trial tried to compare steroid implant versus systemic therapy. And in initial first few years, we all felt that the steroid implants were better than the immunotherapy. But over a period of 7 years, it was found that the results were almost same, and the immunotherapy gave a better control with less fluctuations of the uveitis. Many times we feel that these drugs are very toxic. No, they aren't. They are less toxic than steroids. But yes, we have no experience of giving these drugs in our MBBS time. Very few physicians give it. So we need to team up with clinicians and learn from them how these drugs are given. Methotrexate is given on a weekly basis. Beyond 15 milligram, it's always preferable to give subcutaneous up to 25 milligram, and you need to give folic acid with it. The commonest is counts go down and the LFT. The LFT gets affected. So you need to do that initially every 2 to 4 weeks and then every 3 months. So the biggest contraindication is that yes, both men and women would want contraception because this is toxic and it cannot be used in pregnancy or for breastfeeding. As I mentioned, the common side effect is diarrhea, hepatotoxicity, and sometimes even hair loss. Second commonest drug used is azathioprine. It is quite effective and you can go up to 200 milligram, say 2.25 milligram per kg body weight. Some people have an idiosyncratic reaction and they are supposed to have a TPMT enzyme deficiency, which you can test prior to starting treatment. Problem is that this also causes bone marrow suppression. Sometimes it's so severe that you need to hospitalize and the counts go very low and you need transfusions. It requires better monitoring. You need patients with regular follow-up and good test. Methotrexate is one where you can, even if you miss a follow-up, the patient is not going to have a life-threatening. Mycophenolate mofetil is somewhere between them, which requires less monitoring but requires daily dose. You can go up to 3 grams. Generally, we start with 500 milligram BD, and you need to check the LFT. It is the costliest of those three. So methotrexate being the cheapest. Then comes azoran and mycophenolate. So all seem to have equal efficacy. Some studies showed some superiority, but one study from Dr. Ratnam has shown that mycophenolate and methotrexate are equally effective. These two drugs, cyclosporine and tacrolimus, are less effective, but they can be inefficient in certain vasculitis. So now we have a newer drug groups called biologics, which actually inhibit a specific chemical with like TNF inhibitors or B-cell inhibitors, where you find that their efficacy is much more. The commonest ones being TNF inhibitors, and that is adalimumab, infliximab. The B-cell is rituximab, which is more used for scleritis and orbital inflammatory disease. Tocilizumab, IL-6 inhibitor, is used for vasculitis. And the new small ones, which are not actually biologics, are the varstrip and tofacitinib, act at the level of the intracellular and prevent the effect of various blockades. So you remember that any immunological you give, you need to rule out infection, get a X-ray, hepatitis B, C, HIV test done. In biologics, a patient can become ANA positive. The side effects are multiple sclerosis can get aggravated, ANA positivity, and heart failure and malignancy. These are relative contraindicated. Remember that all these infections, drugs can cause infection, and we need to vaccinate people before we start them. The side effects are activation. So in the small cell JAK inhibitors, we have a lot of herpes involvement, and in TNF, TB can precipitate. So when do you want to start? Whenever you feel that at the beginning the steroid is not working effectively, to come down to 0.5 milligram by the end of 1 month, think of starting the second line drugs. And if they are inadequate response in 3 to 6 months, use biologics. Always rule out autoimmune other diseases, demyelinating disorders before you start them. And both methotrexate and MMF is generally not used in pregnancy. So how do I monitor these patients? We want, one, the clinical resolution of the uveitis. We want it on imaging. The biomarkers are also negative, and the systemic side effects are least. So a disease will be inactive when you have a drug-induced inflammation when the cells are less than 0.5. The relapse period should be at least 2 years before you start tapering, and you taper these drugs over 3 to 12 months at 4 to 6 weeks interval. We do not need to do a stepwise. If we feel that the patient has severe disease and we feel the steroids are not acting, we can go to cyclophosphamide induction, or you can start biologicals. You can go from step 1 to step 4 whenever you see patient benefit is. So already steroid has been mentioned. Thank you so much.
Thank you, Dr. Amit, for the very informative talk on systemic immunosuppressive therapy and also highlighting the practical tips. Now I invite Dr. JB sir to share his experience and to give us tips on immunosuppressive therapy. Over to Dr. Biswas sir.
I think Amit has done a great job. He has got a lot of experience of using the immunosuppressive and biologics. He works with the rheumatologist very closely. One of the area where I give immunosuppressive like methotrexate is the children. Children with the GIA, I don't think that the steroid is a good choice. As soon as possible, I put the patients on methotrexate. That is the drug of choice in children with GIA. Another area where I switch over to immunosuppressive is the Baser's disease, where I put the patients on either immunosuppressive and preferably biologics nowadays, adalimumab in my drug of choice. And I find quite a significant improvement or significant control of inflammation, and it has been very helpful to me. So these are the one which I use it in immunosuppressive. More and more, I'm going to I'm using the immunosuppressive and biologics nowadays, and not that I always depend on rheumatologist. I myself start often the immunosuppressive, but biologics I take the help of rheumatologist most of the times. But immunosuppressive I myself start and modulate the drug, titrate the drugs.
So one practical thing I'd like to ask, so when the patient's on immunosuppressive therapy, the role of vaccination, usually live vaccines are contraindicated.
Yes.
And regarding the flu vaccines, the prophylactic and those kind of tips, I would like to hear from you, sir.
I tell them that not to take vaccinations, particularly live vaccines. And before the biologics usage that, the preventing that zoster that some people advocate, but I don't use that routinely.
Thank you, sir.
Thank you very much. With that, we move on to the next topic. I see that Partha is always ready for his topic, and Partha is going to now talk about biologicals and uveitis, although Dr. JB said already started. So it's always good to hear you, Partha. Dr. Partha Pratim Datta is from Shankar Netralia, Senior Specialist in Uveitis Department over there. Over to you.
Thank you, ma'am. I hope I'm audible also. And so good evening, friends. So I would like to thank Dr. Padma Malini, ma'am, and USI and AIOS for inviting me to speak on biologicals in uveitis. So we treat uveitis with the help of immunomodulation. Now, immunomodulation is the strategy of altering the immune system's response to reduce the inflammation and manage the disease. Now, immunomodulatory therapy involves the use of the medications that adjust the immune response, and this treatment aims to achieve more controlled and balanced immune reaction, thereby decreasing the inflammation and preventing tissue damage. So if you consider here, you can think corticosteroid as the workhorse of the primary uveitis treatment. Immunosuppressives, you can think it as a strategist, because if you are planning the long-term management of the uveitis control, then immunosuppressives are excellent choice. And biological, you must consider them as a special forces. Now, if you ask the basic difference between these three, if you the key differences between corticosteroid and immunosuppressives are that the steroids are not cytotoxic to the lymphocytes. That means they don't kill the lymphocytes. Instead, they redistribute the lymphocytes, especially the T lymphocytes, from the intravascular space to the extravascular space like spleen, bone marrow, and lymph nodes. Whereas if you see here, the biologic, they work by targeting the spatial parts of the immune system and its signaling. So think them as a specialized agent that can come down the specific alarms that should not be going off. For example, if a particular signal in the body is mistakenly telling the immune system to inflame and damage your eyes, then a biologic can block that signal, and by doing so, it helps to reduce the inflammation and ease symptoms of uveitis. Now, The biologicals are the group of biological active proteins and monoclonal antibodies that develops with the help of biological techniques rather than pure chemistry. Now, they are the inhibitors of various cytokines. They do, as I said, the targeted immunomodulation and reduces the systemic adverse effect. Now, broadly, we term them as a MAB, like monoclonal antibody, and sept, where the suffix sept denotes the fusion protein. So kindly note that the ranibizumab and the aflibercept, though these are the biological agents, they are specifically termed monoclonal antibody or anti-VEGF agents, probably due to their targeted use in the ophthalmology. Now, you can identify the chemical nature of a biological drug from its name. The suffix zimumab denotes the chimeric monoclonal antibody. That means they are typically composed of 65% human protein sequences and 35% from a non-human like mouse. So, for example, includes rituximab, the infliximab. Similarly, you can identify humanized and full human from their suffix like zumab and umab. So, as you one thing you must know that that chimeric monoclonal antibodies has the highest immunogenicity, and they can cause a lot of allergic reaction, whereas the human monoclonal antibody, they cause least amount of such allergic reaction. Now here I have only highlighted the drug which are being used to treat the uveitis. So you can see here the infliximab, etanercept, and the adalimumab. These are the cytokine inhibitor. They inhibit the TNF alpha and also called TNF blocker. Now here you see the tocilizumab, the drug like tocilizumab, they act on the cytokine receptor and block the signaling pathway. Whereas there are drugs like rituximab which directly act on the lymphocytes and can destroy the inflammatory pathway. Now, we have published 4 case series on biologicals, including the first case series on biological in uveitis from India. You can see here the 14 patients with HLA-B27 associated were treated with anti-TNF alpha blocker, and in majority of the cases, the indication were primarily systemic involvement, but ocular inflammation benefited equally from the treatment. The next series was on the treatment cases of uveitis refractory to one or more immunosuppressives, and the patient achieved remission with the biological therapy. The cause of this treatment-resistant uveitis was Behçet disease, and recently we have published, it got accepted for the children, biological agents in children, and here we have treated the children who are not responding to the conventional immunosuppressives, and the causes were Behçet disease, Vogt-Koyanagi-Harada disease, and Crohn's disease. So we can summarize the indication of the biological in uveitis as primary indication where you can straightaway start the biologic, like in Behçet disease, in children, the juvenile idiopathic arthritis, and in patients with necrotizing scleritis. Whereas HLA-B27 associated uveitis, if it is associated with systemic association, then you can consider biologic, and the resistant cases of the sympathetic ophthalmia, Vogt-Koyanagi-Harada disease, and chronic pars planitis can be used. Now, I'll just conclude with this 3 things, that the good, the bad, and the ugly of the biological. So the good is that the very useful treatment option in treatment-resistant cases, it is available as injectable formulation, so the compliance is much higher in patients, and relatively faster onset of action. Now, if you take a drug, for example, the adalimumab, the Tmax of after adalimumab after single injection, 40 mg single injection is 131 hours, which is roughly 5.5 days. Now, this suggests that this drug can reach peak concentration in the blood about in 5.5 days after administration. However, the onset of this clinical action can occur little bit like, so we can take it like more or less 3 to 4 days. Now, coming to the one example here, I want to give example how it can be beneficial. This 52-year-old lady who presented with necrotizing scleritis and was being treated with a lot of immunosuppressive and oral steroid, but still there was active scleritis. And as you can see that her intraocular pressure was so high in spite of 3 AGMs and oral acetazolamide. So it was in need of a Ahmed glaucoma valve surgery, but the surgery was not possible because there was this active inflammation. So in that case, we treated the patient with subcutaneous golimumab, which is anti-TNF alpha blocker, and oral methotrexate, and subsequently we could operate the patient and control the patient's IOP. Now, the bad part of the biologics are the cost of 1 month treatment. If you see that in blue color box, I have mentioned the 1 month cost of treatment with prednisolone, methotrexate, and azathioprine. Whereas if you see the cost of treatment with this commonly used biological for a month, it is much, much higher. And that is very challenging for us to treat these patients with biological in a country like India. Now, just coming to the last point, that the ugliest part of it is that increased risk of infection, and all ophthalmologists should be aware of that. Even if you are examining a patient who is on biologic for some other different reason, for example, the treatment of rheumatoid arthritis or some other systemic disease, you must screen this patient regularly. You must understand that the TNF alpha is one of the primary defense system against the mycobacteria. So when we are using the TNF alpha blocker in a TB endemic country, the patient should be monitored very closely. Other than TB, there are risk of hepatitis B and C infection. It can actually there can be reactivation of the varicella zoster virus and many other infection. Now, if you see here, this is a reported case by us where a 14-year-old male was a known patient of JIA and was being treated with methotrexate and adalimumab for a long time. He developed the pulmonary TB after 9 years of treatment, and the patient was asymptomatic when came for a routine checkup. But while examining the patient's eye, we could see a choroidal nodule, which subsequently we treated with oral steroid, and the patient recovered from the uveitis. So this is another patient of GIA on adalimumab and methotrexate for last 4 years, and the patient was severely immunosuppressed because of the systemic disease, and there was still, in spite of that, there was recurrent attack of anterior uveitis, and one day he landed up in our clinic with significant vitritis, and you can see 2 linear patches of retinochoroiditis, and subsequent investigation revealed that it was a case of toxoplasma, ocular toxoplasmosis. So one must be aware of the side effects of this therapy, and it's in medicine, it's all about the evidence based, and it's all about balancing the risk of treatment versus the reward of the treatment. So you have to balance that how much adverse effect of treatment is involved versus how much the resolution, and you can save the eye. Thank you for your patience here.
Thank you, Partha. I think that was an excellent presentation, and it's so heartening to know that you've also published and have first in series from India about the use of biologicals in various indications. So with that, we'll have Dr. Soumya Basu come in. Dr. Soumya Basu is the head of uveitis across the LBPI network, and he is also going to give us his comments on biologics in uveitis.
Thank you, Somashila. Actually, Partho's presentation was so good, there is hardly much for me to say. It was probably one of the most lucid presentations on biologics that I've come across. I liked his point on classifying steroids, immunosuppressives, and biologics as the workhorse and the strategist and the special forces, respectively. But for the younger viewers today, we can say that in the years to come, the biologics will move from the special forces to the workhorses. It's only a matter of years. So it's very important that we understand this very well. One point where I might disagree a bit with what Partho mentioned was the use of biologics in JIA. Still none of the guidelines that are available for JIA mention it as the treatment of choice for at the onset. While I have done it myself and I've got very good results with that, and many people do it, but the guidelines still don't ask you to start biologics right at the onset. So that it's only after using methotrexate for at least 2 months that, or 3 months rather, that you should be looking at biologics. I think rest of it is very well covered. There's really not much for me to say. Thank you.
Thank you, Soumya. A very interesting topic, but then in the interest of time, we move on to the next topic. So this is a shift in topic now. And I welcome Dr. Samindra Karkur, who is going to talk to us about conquering viral uveitis and its management strategies. Over to you, Samindra.
Thank you, ma'am. Thank you, AIOS, ARC, and USI, especially Padma Malini, ma'am, for inviting me in this session. Is my presentation visible?
Yes.
Yes.
Yes. Yes.
I am not able to see it.
You know by heart.
Okay.
So you can stop sharing and share again, I guess.
Yeah. So the topic is conquering viral uveitis, the management strategies. And it's very hard to follow suit after Dr. Partha with his lively and such an illustrated presentation, but I'll try my best. My presentation is not moving. Okay. So viral uveitis, these are the important causes of infectious anterior, posterior, and panuveitis. Anterior uveitis is usually caused by HSV, VZV, anterior uveitis. In acute form, it is Posner-Schlossman syndrome. In the chronic form, the viruses can cause CMV anterior uveitis, CMV associated Fuchs uveitis syndrome, or rubella associated Fuchs uveitis syndrome. In the posterior segment, they can present as acute retinal necrosis, progressive outer retinal necrosis, non-necrotizing herpetic retinopathies, and optic neuropathies. The etiologies for viral uveitis can range from commonly encountered HSV 1 and 2 to CMV, VZV, HIV, measles, rubella, arboviruses, and rarely Zika and Ebola viruses. I feel the best way to drive home a point is with cases. So this is my first case where a 38 years old male presented with blurred vision for about a month. You can see that there are pigmented KPs on the endothelium, and the IOP at presentation was 48 millimeters of mercury. The right eye had cells 3+, there was flare, and there was some kind of a ectropion-like curling of the iris at the pupillary border. The cup disc ratio was 0.7. This patient has had multiple attacks in the past. The angle was heavily pigmented. Patient was treated with topical steroids earlier on several occasions with obvious recurrences. The notable features of viral anterior uveitis are sectoral, patchy, or diffuse iris atrophy, depending on the etiology. These are hypertensive uveitis, so they are usually associated with increased IOP in the acute attack phase. There are pigmented KPs or stellate KPs with diffuse or central distribution on the endothelium. The management strategy in such cases is to have a high-frequency topical steroids initially with slow tapering to prevent rebound inflammation, anti-glaucoma, oral or topical as suitable, and AC TAP for PCR. In this case, it was positive for HSV1. TAP valacyclovir has a very good bioavailability as compared to acyclovir, and 1 gram TDS for 1 month is given for acute phase, followed by maintenance dose for about 3 to 6 months, depending on the response. Anti-glaucoma medications we were able to stop in this patient with continued IFT monitoring, and patient maintained remission with maintenance therapy. This is a second case. He was a 34-year-old male with blurred vision for about a month. There were classic diffuse stellate KPs, small, different sizes, small and medium sized, present all over the endothelium, and even you can see an enlarged corneal nerve shown by the yellow arrow. At the same time, if you see on the picture on your left, there are Keppes nodules, and there are multifocal deposits of multifocal cellular deposits on the iris surface with a moth-eaten appearance of the iris. It's a classic case of Fuchs uveitis syndrome, and even in such cases, sometimes the inflammation can be as exuberant as shown in this case. Topical steroids may be used if the inflammation is significant and during acute exacerbations. Complete quiescence in acute uveitis is neither expected nor achieved. Overuse of steroids is avoided in order to avoid complications like cataract and glaucoma. Counseling of such patients is helpful because most of the times the patients are unhappy, my vision is blurred. This is one of the most underdiagnosed and overtreated entity and associated with CMV and rubella. So the third case is he was a 31 years male. Diminution of vision in the left eye for 10 days. Vision was 3/60, right eye was the normal limits. He was a known case of non-Hodgkin's lymphoma for a year on CHOP regimen, chemotherapy, and radiotherapy. Patient presented with this granular creamish lesion in the macula in the left eye. This is one of those cases where the standard 55-degree color fundus camera is more useful than any other ultra-wide field imaging. On FFA, there was some hyperfluorescence with disc staining. So this was a case of granular type of CMV retinitis in non-Hodgkin's lymphoma, non-HIV patient. CMV PCR turned out to be positive. Patient was HIV negative. CD4 count was 119 and TLC was 2600. Patient was treated with intravitreal ganciclovir, 2 milligram per 0.1 ml. The dosage is given twice a week until the lesions heal. My next case is a 42 years old female. She presented with diminution of vision for about a month. Anterior segment had cells 1+ flare, vitritis, and she was a newly detected diabetes patient with uncontrolled HbA1c of 9.8. She was hypertensive, right eye was within normal limits. On examination, she was found to have full thickness retinal infiltrates with multiple satellite lesions, presence of perivascular cuffing and disc edema. On FFA, you can see multiple areas of perivascular cuffing. Initially, we thought that this could be a case of endogenous endophthalmitis, and we moved ahead and gave her an intravitreal vancomycin and ceftazidime. However, the vitritis increased and the lesions became larger. The routine systemic endophthalmitis workup was also negative. However, the TAP which we sent was subjected to investigations in PCR, and it turned out to have a very high level of varicella zoster virus DNA. Patient was immediately started on oral valacyclovir 1 gram TDS, and we can see a serial resolution of the retinitis lesions, and as seen over here. So this was a challenge because the patient had non-peripheral lesion, focal lesion, and she was an apparently immunocompromised patient with uncontrolled diabetes. So AN should be suspected if there is a rapid progression, occlusive vasculopathy, vitritis, and optic neuropathy. My next case is that of a 50 years old male. Right eye counting fingers vision and left eye denying PL. In the right eye, we can see multifocal retinitis lesions with vasculitis, some chorioretinal hypopigmented scars. The left eye was denying PL, and patient had lost to a similar problem last year, for which he took some local treatment. However, he lost this eye. Fluorescein angiogram shows multiple areas of hyperfluorescence with staining in late phase. Systemic history was not forthcoming. Uveitis workup was negative. However, we subjected the patient being one-eyed to diagnostic vitrectomy, and cytology yielded inflammatory cells. No neoplastic cells were noted. PCR turned positive for toxoplasma and HSV. The patient was started with treatment, a combined treatment with clindadexa and ganciclovir. This is the picture from before, where the lesions have actually increased, because by the time the reports were received, the lesions had already started progressing. But the moment PCR results were obtained, patient was treated with IV acyclovir 500 milligram TDS and intravitreal ganciclovir combined with clinda and dexa for toxoplasma. So mixed infections are common in HIV and immunosuppressed patients with minimum vitritis. This patient was not forthcoming with his seropositive status, and we could save this eye. The drive home point is mixed infections in an immunocompromised patient, especially HIV. My last case for the day is recently seen by me, a 16-year-old male, known case of ALL, presented with sudden onset, rapidly progressive diminution of vision both eyes for a duration of 2 weeks. His vision was counting finger 1 feet in both the eyes. He had an episode of fever 10 days ago. TLC, when on investigation, TLC was 37. Patient had neutropenia. Hemoglobin was 8.8. He was a known case of B-cell ALL since 2022 on augmented BFM high-risk protocol for pediatric ALL, and currently the child was on 6th maintenance cycle. This was the presentation where you can see extensive perivascular infiltration, frosted branch gingitis pattern with hemorrhagic retinitis in both the eyes. The left eye was more severely, the right eye was more severely involved compared to the left. The OCT also shows features of full thickness retinitis with inner retinal edema. This patient, we sent PCR from both vitreous as well as serum. However, to our surprise, the PCR turned out to be negative. MRI, brain, and CSF analysis was done by pediatric oncologist just to ensure that there's no recurrence of the ALL, intracranial recurrence of ALL, which was again normal. So we, based on our clinical diagnosis, we treated this patient with intravitreal ganciclovir injection in each eye. The retinitis responded well. However, both eyes developed tractional retinal detachment within 2 weeks of starting intravitreal ganciclovir therapy. First, the right eye developed a tractional detachment, followed by the left eye. And it didn't stop there. The tractional retinal detachment converted into a combined mechanism retinal detachment in both eyes within 21 days of starting the therapy. Patient was also put on oral valganciclovir, and we had to take this child for surgery. These are post-op pictures. In the right eye, a large area of retinectomy had to be done because the area of fibrosis was so adherent to the retina that there was no separation or peeling possible. The left eye, fortunately, the area of retinitis was nasal, so we could save the posterior pole in this case. Over a period of time, the patient started developing optic atrophy and cord-like vessels. The vision at present currently is hand motion in right eye and counting finger 1 feet in the left eye. So take home with this is that viruses are an important cause of infectious uveitis. Diagnosis is primarily based on typical clinical signs, and 99% of the viral uveitis, especially posterior uveitis, can be diagnosed in the clinic without any special investigations. Lab tests, including PCR assays, may aid in the diagnosis and management, especially in atypical presentations. The treatment requires careful monitoring of therapeutic response and prevention of recurrences in the long term. Thank you very much.
Thank you, Samendra. I think that was once again a very comprehensive presentation and brilliant cases which were illustrating the points that you highlighted in the summary. So we asked Professor Rathinam to give her comments for this presentation.
Yeah, it was a wonderful presentation. The only thing, we have very good understanding in bacterial diseases and lesser understanding in fungal diseases. As far as virus is concerned, our knowledge is very much limited. If it is herpes zoster and herpes simplex, definitely we have drugs. And if we have herpes zoster and herpes simplex, our primers are more sensitive and we are able to diagnose. Surely we have quite a lot of new viruses coming and we do not know whether we have in our population or not. As you presented in the last case, we were not able to know the etiological diagnosis. So we failed, but still you surgically you managed. So probably we have to increase our basic understanding of viruses. What do we have in our population? And antivirals are very much limited. And maybe if we differentiate herpes zoster simplex from CMV virus, then we can change over to valganciclovir. Still we can get better results. But other than these drugs, we don't have any other drugs. So maybe surveillance is very, very important. And we should know what else we can do to improve our drug delivery and as well as availability of drugs or invention of new drugs, maybe our next generation will be learning more and achieving more. Thank you.
Thank you very much, ma'am. That was brilliant comments, I would say, and summary of where we stand with viral uveitis. So we saw we saw the clinical features, we saw how to investigate, we saw medical management, and then we also saw viral uveitis. So, but then sometimes medicines fail us, and so we need to do some surgical procedures for uveitis. And Dr. Abhilasha Baharani is going to take us through uveitic eye procedures. Abhilasha is a senior specialist at NeoRetina from Hyderabad. Hi, Abhilasha. It's wonderful to see you at this forum at least. Are you muted, Abhilasha?
A very good evening to all.
Good evening.
I'll just share my screen. I thank Dr. Padma Malini and AIOS ARC for this kind opportunity. I hope my slides are visible.
Not the slides, we can see your computer, but you need to share your presentation.
Okay. Okay, now?
Yes, can you go to full screen and then we're ready?
Yes. So I'll be talking today on navigating uveitic eye procedures. So why uveitic eye procedures are different? We all know about the basics of immune privilege, the blood-retinal barrier, immunoinhibitory substances within the eye, and anterior chamber associated immune deviation that work to protect the delicate visual axis from damage by inflammatory processes, and breakdown of these processes leads to bystander damage from infection and from development of uveitis. So when we are dealing with uveitic eyes, we are dealing with already compromised eyes, and therefore we have to be very careful in choosing the right procedure and doing it meticulously. So there are two types of procedures, diagnostics and therapeutic procedures. In this talk, I'll be dealing only with the diagnostic procedures because they are very specific to uveitic eyes. The first procedure is anterior chamber tab. Indications are atypical clinical presentation, recurrent uveitis of uncertain etiology, therapy refractory cases, and immunocompromised or elderly patients who present with misleading presentations and where there is a limited fundus view. So the diagnostic yield of PCR, real-time PCR, is very good in detecting pathogenic DNA and RNA. There is high diagnostic sensitivity and specificity for herpes viruses, CMV, and toxoplasmosis. Cytokine biomarkers in viral uveitis, we see increased interleukin-6 and interferon gamma. High interleukin 10 and IL-10 by IL-6 ratio more than 1 are indicative of primary intraocular lymphomas. The myeloid differentiation 88 gene mutation, the most common mutation, L265P mutation, is a valuable tool for diagnosis of B-cell lymphomas. Now, these cytokine biomarkers are most commonly used in vitreous biopsy samples, but recently they have been shown to be useful in aqueous samples as well. The technique, either we must go near the superior limbus or inferior limbus with a 2 ml syringe and a 26 gauge needle. Or you can enter at the 9 o'clock position and direct your needle towards the 6 o'clock or 12 o'clock position. The needle should be tangential and at the level of mid-peripheral iris and parallel to the iris plane away from the cornea and the lens. Aspirate about 0.1 to 0.2 ml aqueous fluid. Never go directly perpendicularly inside towards the lens. In this video, we can see that the needle is at the mid-periphery. Generally, it is taken without the plunger. The syringe is not connected to the plunger, and with the other hand, press the cotton bud so that the fluid passively enters the syringe. And always take care that you're nowhere closer to the iris or the lens. Potential complications are Amsler sign, endophthalmitis, corneal abscess. We might have to cornea, iris, lens, and corneal infections. Coming to the next procedure, that is vitreous biopsy. Indications are again acute sight-threatening disease, where culture is required, where you are suspecting bacterial or fungal infections, when there is suspected malignancy. In cases of chronic uveitis, which are unresponsive to conventional immunosuppressive treatment, atypical presentations, and inconclusive laboratory workup. Now, this is a case who had very severe visual loss for the past 1 year post-cataract surgery, and he had been on several courses of topical and oral steroids. Now here you see that there are some granulomatous KPs, there are inflammatory deposits on the IOL and very dense vitritis. So such cases do benefit from vitreous biopsy. The diagnostic yield of real-time PCR is very good. And the vitreous biopsy samples provide reliable culture reports. The sensitivity is about 57.4%, which is much higher than compared to aqueous samples. We all know that the antibodies in the vitreous are more specific than the antibodies in the serum, especially when we see viral diseases. So Goldman-Whitmer antibody coefficient can be calculated. You can analyze the antibody levels in the vitreous by ELISA, and the Goldman-Whitmer antibody coefficient is calculated. If it is more than 3, it is considered diagnostic. I have already discussed cytokine biomarkers in the aqueous tab section. Cytopathology is very useful in diagnosing intraocular malignancy. And adjunct to cytopathology is flow cytometry and immunohistochemistry, which also detect the tissue-bound antigens, which helps in detecting the type of lymphocytes that we see, whether they are CD4 or CD8 cells. And monoclonal B lymphocytes detected by immunohistochemistry are diagnostic of B cell lymphomas. Now, there are 2 types of procedures for vitreous biopsy. One is needle aspiration and pars vena vitrectomy, but needle aspiration is definitely not preferred because it puts the patient at higher risk of retinal detachment. Pars vena vitrectomy decreases the risk of RD. There is better diagnostic yield. It removes the load of microorganisms and inflammatory cells. There is better diffusion of intraocular medications and better view of fundus postoperatively. Now, techniques of PPV, if you want to take an undiluted vitreous sample, vitreous biopsy can be done under air. It provides wider view of the fundus, better identification of residual vitreous, more stable air vitreous interface, and it helps to evaluate the entire retina thoroughly. And we can also inject antibiotics if necessary. A standard 3-port vitrectomy is done to take 1 ml vitreous sample. Now, in this video, when you are priming the vitrectomy machine, you can connect the infusion line with air, flush the vitrector with air so that you can remove any fluid remaining there. Once you have flushed the infusion line as well as the vitrector with air, you can connect the infusion cannula back to the infusion line, and the aspiration arm is connected to the syringe. Switch off the air temporarily. Once the infusion tip is within the vitreous cavity, you can start the air again. And when the surgeon is doing the vitrectomy, the assistant can take the sample and you can change as many syringes as required. So the vitrectomy is done posterior to the incoming air bubble. This is the intraoperative video where you can see the vitrectomy being done in a case of chronic panuveitis refractory to treatment. Now, vitreous biopsy with PBD induction. Sometimes there are thick vitreous exudates, like in this case. You see there are vitreous exudates with feathery margins and the fundus lesions are not seen. In this case, a specific diagnosis is required because the patient's vision is severely lost. So this is a 3-port vitrectomy. And in these cases, when we do only a core vitrectomy, the diagnostic yield is not good. You might get negative culture reports. This video is running at 3x speed. So PVD should be induced only in experienced hands so that there are no iatrogenic breaks. And you can take the sample from close to the posterior vitreous so that there are higher chances of better culture reports. Potential complications are cataract, glaucoma, retinal detachment, and CME. Coming to the third procedure, a chororetinal biopsy. This is done only in exceptional cases where the diagnostic uncertainty presents with intraocular inflammation and a tissue diagnosis is required. In cases where vitreous biopsy is inconclusive and malignancy needs to be ruled out, and in cases where there is minimal vitreous involvement, the diagnostic yield is much better than complete vitrectomy. The diagnosis is reported in malignancies, fungal infections, viral infections, TB, and toxoplasmosis. So this is a case of suspected malignancy where there is minimal vitreous involvement. And here we see that vitrectomy is being done with a low cut rate, and the sample is directly aspirated and sent for cytopathology and immunohistochemistry. And here we could confirm the diagnosis of lymphoma. So potential complications are retinal break, retinal detachment, subretinal hemorrhage, vitreous hemorrhage, and cataract. So the take-home message is make every effort to reach an etiological diagnosis clinically, learn the right technique of various procedures, choose the safest procedure in your hand or refer the case. Choose the sample site that will give you maximum diagnostic yield, and use invasive tests judiciously only when absolutely necessary. Thank you.
Thank you, Abhilasha. Nice caption. If you change, nothing will change. Excellent presentation. And I invite Dr. Basu, who has a lot of experience in performing both diagnostic and therapeutic vitrectomies, and he can give his comments and his suggestions.
Very well presented, Abhilasha. I think both the topics were covered very nicely, ACTAP as well as vitreous biopsy. I think 2 points need to be highlighted. First is, especially since we do most of these for PCR. So both aqueous and vitreous contain PCR inhibitors. So they're inherently not very favorable for PCR. So that should be kept in mind, that we can have a lot of false negative cases. Similarly, a lot of organisms, and 2 organisms I can tell straight away. One is Mycobacterium tuberculosis. The other is cytomegalovirus. These are also present in the normal healthy individuals for reasons that I can't explain now. So when we see positive PCR for TB or for CMV in a sample where we were not clinically suspecting either of these two, I think we should be cautious in accepting the result. The final point is especially about aqueous tap. So when there are no cells in the antechamber or the lesion is posterior, then it is very unlikely that we'll get a positive PCR result in those patients, because all the organisms we are talking about are intracellular organisms. And if you don't have cells in the sample that you're taking, you're not going to get any positive results. That's all from my side. Thank you.
Thank you, sir.
Thank you, Dr. Basu, and thank you, Dr. Abhilasha. I invite the next speaker, Dr. Mayur Murikke. Is from Bombay Hospital and Institute of Medical Sciences, Mumbai. He'll be talking to us on pediatric perspectives, update in Uveitis care. Over to Dr. Mayur.
Thank you, madam. Thank you, everyone, for having me here. Am I audible?
Yes.
Yeah. So we start with acknowledgements to my teachers from Sion Hospital, LV Prasada Institute, Hyderabad, and my teachers in personal counseling. So my topic for today is pediatric perspectives, updates in uveitis care. And the plan for the presentation is to have 5 perspectives in 5 minutes and then have a representative case in 2 minutes. These are my co-authors. They include a pediatric ophthalmologist, a pediatrician, and a pediatric rheumatologist. To introduce the topic, childhood uveitis is unique but common situation faced by the pediatric ophthalmologist and the uveitis specialist, and it is unique because it involves certain important differences from uveitis in adulthood. So coming to the first perspective, that on presentation, and what's known is that in adults, uveitis is often accompanied by redness, pain, watering, and decrease of vision, but it is not so in childhood uveitis, especially in JIA, where it is known to be silent, that is in a white eye, anterior, and characterized by what you can see as band-shaped keratopathy, posterior synechiae, and complicated cataracts. Now, there is this entity called juvenile spondyloarthritis, and they are a little different from the patients of JIA. In children with JSPA, there is a symptomatic anterior uveitis with many patients having redness, pain, and light sensitivity. In fact, patients with JSPA can be separated into 2 subgroups. The first group, which is less than 4 to 5 years of age, and they are similar to the children with the early onset oligoarticular and polyarticular JIA. There is a female preponderance, there is dactylitis, and a higher incidence of ANA positivity and uveitis. So this group is similar to the JIA. And the second group includes children who present at a later age. So that is, they have a later age of onset. They are more likely to be boys, and they have enthesitis, sacroiliitis, and psoriasis. One such patient we dealt with throughout 2018 and 19. He was a 13-year-old boy with a spondyloarthropathy, had been on treatment for 5 years. So he's been on treatment since 8 years of age, HLA-B27, presenting with a severe non-granulomatous panuveitis. He had been serially treated with prednisolone, sulfasalazine, subcutaneous methotrexate, then infliximab. But finally, the uveitis and his systemic condition came under control with fortnightly adalimumab. We were faced with a cataract, and cataract extraction in such cases can be difficult, and a posterior approach may be advisable, especially if the preoperative UBM shows cyclitic membranes and a preoperative B scan shows something like a shrunken pre-icicle eye. That is what we were faced with in this patient. We took the posterior approach, used iris hooks, had a fibrous anterior capsule to deal, and were able to put the IOL on the sulcus with silicone oil. And this is the final visual outcome. The best corrected visual acuity remained at around 1 to 2 meters, and that is because of a macular edema, which had led to a macular scarring that he had. Coming to the perspective two, that is to emphasize the use of early DMARDs. This is something that definitely needs to be updated among all of us, especially general ophthalmologists. In adult uveitis, the initial attacks may be treated with topical or oral steroids with the possibility of a watchful expectancy and a calculated delay in the introduction of DMARDs. DMARDs are the disease-modifying anti-rheumatic drugs. But in childhood uveitis, especially those in relation to JIA, there is a early introduction of DMARDs, which is almost mandatory. The drugs of choice being methotrexate and biologics like adalimumab and other agents. There are certain zero tolerance issues which are to be emphasized when one deals with childhood uveitis. The 2 zero tolerance issues are a zero tolerance to inflammation. That is, one should not tolerate even a a slight bit of inflammation, even if that is limited to the anterior segment, that is to prevent BSK and complicated cataracts, and a zero tolerance to the requirement of oral steroids. So one should use DMARDs to the effect that one is able to taper and stop oral steroids. In adults, one works with around 5 to 7.5 milligrams of oral steroids, but in childhood uveitis, the aim should be to try to stop oral steroids to prevent all the ill effects of steroids on the growth of a child. Then there are these entities which are monogenic autoinflammatory syndromes in children. And one needs to know that these are those which are caused by pathogenic genetic variants in innate immune system and lead to a dysregulation and aberrant activation spontaneously or by minimal triggering. There are quite a few of them. FMF, TRAPS, MKD, CAPS, and the Blau syndrome. Of this, we have had the opportunity to deal with patients with MKD and Blau syndrome. Coming to the last perspective, that in relation to screening and follow-up, what is known that is that patients with JIA require a very close monitoring, a 3 to 4 monthly monitoring and eye checkups given its silent and insidious nature. But what needs to be updated is that while we are talking about a very close ophthalmic screening every 3 months in JIA, who are ANA positive and less than 7 years of age, in JSPA, especially the second group, because there is presence of redness, pain, watering, and decrease of vision with each attack of uveitis, there is a chance of spacing out the follow-up visits, especially as the child grows older. And this can especially be done in those who are ANA negative and who present at more than 7 years of age. Coming to the representative case, the boy, a 9-year-old boy, a known case of Blau syndrome, confirmed with a skin biopsy and the genetic test, presented to us. This is in the middle of COVID. You notice that it is October 2020, with a best corrected vision of 6/9 in the right eye and finger counting 3 meters in the left eye. You can see the photograph that we put there, which shows the joint deformities. Slit lamp examination of the right eye showed some old corneal scars with a trace lenticular opacity, a single large KP signifying activity, and a posterior subcapsular cataract. In the left eye, there were multiple superior old interstitial keratitis with vascularization, a large central lenticular opacity, and posterior synechiae, which you can see once the pupil has been dilated. I put the third photograph there to try to show the corneal scarring. The patient had a normal intraocular pressure and fundus findings. Our impression was that he had a bilateral chronic granulomatous anterior uveitis and a complicated cataract. We knew that the disease was active even in the right eye. The patient was started on topical and oral prednisolone along with subcutaneous methotrexate, which was at the dose of 20 milligram per week along with supplements. 12 weeks later, disease quiescence was achieved in both eyes, the right eye achieving a best corrected vision of 6/6 and the left eye had a vision of 6/60, albeit with a progression of cataract. The oral steroids were tapered, ultimately stopped. The immunomodulator was continued, and the patient was planned for left eye cataract surgery. The left eye cataract surgery was actually done 2 years later, and this is the photograph of the patient 6 weeks post cataract surgery. The cataract surgery was uneventful, and we were able to give the patient a best corrected visual acuity of 6/9 and an uncorrected near vision of N10. We put the left eye photograph showing the posterior PCL and also showing the scarring of the cornea superiorly. For those who are interested in further reading, and especially in an algorithm for management, I would definitely recommend this article. If you would have all noticed, we have been in this presentation, we have dealt mainly with the non-infectious and the autoinflammatory pediatric uveitis. In pediatric uveitis, there are infectious agents as well. And I would suggest that anybody interested in management of pediatric uveitis should review this article. There is a very extensive treatment algorithm which is put there involving the use of steroids, immunosuppressants, and also biologics. To conclude, the last slide, in pediatric uveitis, always beware of masquerades. We have been talking about this in uveitis of the young and the old. Always beware of masquerades. Thank you.
Thank you, Dr. Mayur, for excellent presentations, and thanks for highlighting zero tolerance of inflammations in children. Not only we control inflammations, we have to prevent the amblyopia, and a lot of other issues are there in pediatric age group and dealing with the pediatric uveitis. I invite Dr. Kalpana Babamurthy to discuss this presentation. Over to Kalpana.
Thank you, Dr. Padma. And firstly, I would like to congratulate Mayur. He put it very nicely as 5 perspectives, and it is quite easy for somebody who is listening to take home the message actually intended. So my thing is, I think you've covered everything in it. What I would like to just add is, I think in children, when we compare it to adults, the inflammation which we see are definitely much more aggressive than what we would see with adults. So, us dealing along with pediatric rheumatologist is the key. Because if you send them to an adult rheumatologist, the doses which are used, especially the immunomodulators as well as the steroids, generally we tend to use steroids for a longer time in these kids till the immunomodulator starts working. And usually it is much more aggressive than what we see with adults. So that will be my first take home. I think we should collaborate with a pediatric rheumatologist, or if you don't have one, at least a pediatrician who would be able to monitor the systemic side effects or the well-being of this child. And a lot of counseling is important when we are dealing with pediatric uveitis. Especially the parents, even for us also, when we examine them, it takes some time for us to get used to the child to get used to us, and the parents are definitely anxious. And as Padma said, amblyopia is something which we need to take care, and this is something we should keep constantly in our mind. I just have to differ from you from that one point with blouse, so these are, we have one of the largest series of blouse actually, and what we have seen in these patients are, they're so refractory uveitis with so much of relapses and remissions. So initially they do well, and they have to be aggressively treated in the beginning. Otherwise, over a period of time, they become so refractory to medications. So these are cases, again, that putting the intraocular lens is always a dilemma, whether to use it, because we've gone in and removed lenses in many of these cases with granulomatous uveitis. So that is one thing I think we should exert a word of caution before we plan any procedures, especially surgical procedures with relation to implantation of lenses in these eyes, both JIA as well as granulomatous uveitis. Apart from that, I think you've covered it all. The infections, as what Padma said, is again another part and a different spectrum. And you've highlighted mainly the non-infectious subgroup in pediatric uveitis. So thank you so much for this excellent talk.
Thank you, Dr. Mayur. Thank you, Dr. Kalpana. Yes, now we are sorry about running delay. And next we'll move on to the interesting program, Saransh. It's going to be hot and sizzling. We are going to get the list of journal articles from uveitis on a platter by upcoming uveitis specialists. The first presentation is on refreshing insights from latest Sun 2 uveitis classification by Dr. Aditya Patel. He's a uveitis consultant at Crystal Eye Care Center, Mumbai. Over to Dr. Aditya.
Thank you, ma'am. At the outset, I'd like to thank Dr. Padmamali, ma'am, and USI and AIOS for giving me this opportunity. I'll be speaking about refreshing insights from the latest Sun 2 uveitis classification. So, we know that the Sun Group published the results of their first workshop in 2005, where they reported they gave the guidelines for reporting clinical data. This is where they defined several terminologies and gave the inflammatory grading scales. In 2021, they published several articles, a series of articles on disease classification criteria. Now, we need to understand that classification criteria are primarily intended for research purposes, and they're different from diagnostic criteria, in the sense that when there's a trade-off between specificity and sensitivity, the classification criteria emphasizes on specificity and the diagnostic criteria emphasize on sensitivity. So they published a series of articles for classifying 25 of the most common uveitic entities. These are all the entities that they classified. And the goal of this classification was to define a homogeneous group of patients for inclusion in research studies. This is the methodology. So they had an informatics phase where the language was standardized to describe each uveitis type, and a case collection phase where the team put together 5,700 cases in a database, and a case selection phase where the uveitis experts they met and they had a formal consensus with supermajority agreement on which cases represent a specific diagnosis. Then they used artificial intelligence and machine learning to have a training set and a validation set, and then using AI they formed these classification criteria. We can see where they have derived the cases from geographically, that most of the cases were from Europe and North America, whereas we can see that Asia and South America were underrepresented and Africa was omitted. So that is one drawback of this classification. Otherwise, the accuracy of the classification criteria is fairly good. Now let's dive into each of the diagnoses. So I'll just brush up very quickly because there are 25 uveitic diagnoses, and I'll only mention the salient features. When it comes to classifying HSV anterior uveitis, we need to have evidence of anterior uveitis. It has to be unilateral. If we want to diagnose a bilateral uveitis, we need to have a PCR confirmation, and there has to be evidence of HSV virus infection in the eye. So that could be a positive PCR or sectoral iris atrophy in a person less than 50 years. If a patient's age is more than 50 years, it is said to be due to VZV uveitis, or there could be an HSV simplex keratitis. So the VZV criteria are similar as that for HSV, except for that, if the patient has clinically has a herpes zoster ophthalmicus, then that is prima facie taken as a VZV uveitis. Coming to CMV anterior uveitis, there has to be evidence of anterior uveitis with evidence of CMV in the eye via positive PCR. At the same time, while diagnosing, we need to exclude syphilis and sarcoidosis and the other viruses. So for HSV and VZV also, we need to exclude syphilis and sarcoid. And mostly for all the diagnoses, we need to exclude these two entities because they can masquerade many of the other entities. Coming to Fuchs uveitis syndrome, here the important part is that we need to exclude endothelitis and nodular coin-shaped keratic precipitates. And the Sun classification criteria mentions that the uveitis has to be unilateral. However, there are cases of bilateral Fuchs uveitis. And coming to JI-associated chronic anterior uveitis, it has to be an anterior uveitis which is chronic, or at initial diagnosis if the uveitis is of insidious onset. And in GIA, they have excluded enthesitis-related arthritis because that is an HLA-B27 associated disease. And then let's go to Tinu syndrome. Here, so most commonly tubular interstitial nephritis is seen secondary to drug therapy, but that does not result into a uveitis. Most Tinu is seen in rheumatic diseases secondary to SLE or Sjogren or systemic vasculitis and IgG4 disease. So for diagnosing Tinu, we need to have an evidence of anterior uveitis, and there has to be evidence of tubular interstitial nephritis. That can be on positive renal biopsy or by elevated urine beta microglobulin and either abnormal urine analysis or elevated serum creatinine. Going to HLA-B27 associated anterior uveitis or spondyloarthritis. So here HLA-B27 typing is not is not compulsory. Even if evidence of spondyloarthritis is acceptable as per the ASAS criteria. So what is ASAS? ASAS is the Assessment of Spondyloarthritis International Society criteria. And there has to be evidence of anterior uveitis and characteristic uveitis course. So now here the course is very important. It has to be acute or chronic, and it has to be acute recurrent or unilateral alternating course. So these are the ASAS criteria for axial and peripheral spondyloarthritis. So I won't go into the details. Jumping into the intermediate uveitis. So here is where the Sun 2 classification criteria made a distinction between pars planitis and non-pars planitis intermediate uveitis. Going to pars planitis, there has to be evidence of intermediate uveitis and evidence of pars planitis, which they've defined as vitreous snowballs or pars plana snowbanks. So here also we need to exclude multiple sclerosis, syphilis, sarcoidosis, and Lyme disease. Going to multiple sclerosis, we have to have a diagnosis of multiple sclerosis by McDonald criteria and evidence of intermediate uveitis. And of course, we need to exclude syphilis, sarcoid, and Lyme. Coming to this particular subtype, which is intermediate uveitis non-pars planitis type, this is a diagnosis of exclusion, which has been mentioned by the Sun 2 classification. We need to have an evidence of intermediate uveitis and no evidence of pars planitis. That is, there have to be no vitreous snowballs or pars plana snowbanks. Plus, we have to exclude multiple sclerosis, Lyme's, syphilis, and intraocular lymphoma. Coming to the posterior uveitis, we have ARN. So here the new thing is that CMV has been excluded from etiology for ARN syndrome, and we also have to exclude toxoplasmosis by intraocular specimen PCR. So for diagnosing ARN, we need to have a peripheral necrotizing retinitis, and it can either be HSV or VZV viral etiologies, and there has to be a characteristic clinical picture. For CMV retinitis, we need to have a necrotizing retinitis with indistinct borders, with small satellite lesions like these, and immune compromise. Now, the immune compromise can be systemic or ocular, so the patient does not need to have HIV. They can also have just ocular immune compromise, and a clear characteristic clinical picture, which is a wedge-shaped retinitis or a hemorrhagic retinitis or granular retinitis. So the hemorrhagic is seen more around the arcades and the posterior pole, and the granular is seen more in the periphery. Again, we need to exclude other viruses like HSV, VZV, and also toxoplasmosis by PCR. Coming to toxoplasma retinitis, we need to have the characteristic clinical presentation with evidence of toxoplasma in the eye by positive PCR or in the serum by serum IgM antibodies. And or we can have a clinical picture like with the hypertrophic scar in adjacent area of retinitis. One important exclusion here is that if both the IgG and IgM in the serum are negative, then that is an exclusion criteria for toxoplasma. For the multiple evanescent white dot syndrome, it's fairly simple. Patient needs to have a characteristic clinical picture with a characteristic fluorescent angiographic pattern. Here, an important exclusion is the bilateral simultaneous disease onset, because in their study, they found that almost all cases had a unilateral presentation at the onset. Coming to AMPI, again, we need to have a characteristic clinical picture with the placoid lesions, which are very characteristic, and the fundus fluorescent angiography pattern with late staining of the lesion. Coming to birdshot chorioretinitis, here again, HLA-A29 typing is optional. If you have a characteristic clinical picture with bilateral multifocal choroiditis and you have absent inflammation in the anterior and vitreous chamber, then you can have diagnosed as a birdshot chorioretinitis, or you can have multifocal choroiditis with positive HLA-A29. Again, we need to exclude syphilis, sarcoid, and intraocular lymphoma. Coming to multifocal choroiditis with panuveitis, we need to have the characteristic clinical picture with lesion size more than 125 microns. Here, and it has to have a more than minimal vitreous inflammation. Plus, we need to exclude syphilis, sarcoid, and TB.
Okay.
But how is this different from punctatinic choroidopathy? In the sense that the distribution of lesions is different. In MFC-PO, the lesions are more in the periphery and may or may not be there in the posterior pole. Whereas in PIC, the lesions are in the posterior pole or may and may not be there in the periphery. Plus, the size of lesions in PIC is different. It's less than 250 microns. And coming to sebaceous choroiditis, here the FFA pattern is characteristic. It's called block early and stain late at the borders. And this is different from the other choroidopathies such as AMPI, where we have a block early and stain late diffusely pattern. Again, we need to exclude the tuberculosis, syphilis, and sarcoidosis for sebaceous choroiditis. Coming to the pan-uveitis, for Behçet's disease uveitis, we need to have a...
highlight the important one, Dr. Aditya, since we are running late. Yeah.
Sure, I'll just do that.
Exclusion criteria, you can miss it out and highlight the important ones.
Okay, for Behçet's disease, we need to diagnose it using the international study group criteria. And so oral ulcers are mandatory to diagnose Behçet as per Sun criteria. And for sarcoid, serum ACE or lysozyme levels are not required. We just need to have a compatible uveitic picture with evidence of sarcoidosis. For tubercular uveitis, also sarcoid has to be excluded, and evidence of MTB is given by positive IGRA or tuberculin skin test with a compatible uveitis. And for sympathetic ophthalmia, there has to be evidence of more than an isolated anterior uveitis. So that is important, and cases need not be granulomatous in all the cases. For VKH disease, here they've diagnosed it as an early and late VKH and not an incomplete, and probable, which was the revised diagnostic criteria. And for syphilitic uveitis, you need to have a compatible uveitis with evidence of treponema pallidum. This is done by reverse screening algorithm, where we screen first with a treponemal test and then with a non-treponemal test. Also, all cases of syphilis are treated as a neurosyphilis, and all cases have to undergo a lumbar puncture. And this is the treatment as prescribed by them for the ocular syphilis. Thank you.
Thank you, Dr. Aditya, for the excellent coverage of SAN2 classification. And I invite Dr. Biswas sir for his comments.
So I was there in the second year SAN2 classification system. That meeting was held in New Year, and it was just a clinical, it's not a clinical classification, it's a research purpose. This classification was made. And in case of, if you look in the infectious uveitis and anterior uveitis, they have not included TB, and intermediate uveitis also, they did not include TB. We see a lot of TB anterior or TB anterior intermediate uveitis. And they have excluded syphilis for all entities to do the syphilis. If I see an unequivocal case of VKH or sympathetic ophthalmia, I won't be doing serology for syphilis. I don't do it. I don't know what others do it. Theoretically, yes, you can do it. But clinical acumen says me that, a patient have a recurrent hypopian uveitis with fibrin in the anterior chamber, I won't go for syphilis test. I will do the HLA-P27 testing. So this has got limitation. And then Asian countries, the number underrepresented, and it was mostly in North America, and the data has been collected. This is a good exercise with a machine learning method, and we can apply ourselves and develop our own criteria from our country. That's what I feel.
Yes, sir. Thank you so much. That's a most valuable input. So we should work as a team and come out with our own algorithm from a Uveitis Society of India end. Thank you, sir. The next presentation is on collaborative ocular tuberculosis study, that is COTS calculator, a consensus-based decision tool for initiating anti-tuberculous therapy in ocular tuberculosis by Dr. Saloni Desai from Shankanethralaya, Chennai. Over to Dr. Saloni.
So it's Saloni.
See, you're not audible. Can you unmute yourself? Your slides are moving, but you're not able to hear your voice.
Can you see her? I can't see her also.
Okay, sir. Am I audible now?
Yeah, we can hear you.
Yes. Good evening, all. I'd like to thank Padma Malini ma'am, USI and NIF for the opportunity. I'll be presenting a study on the COTS calculator.
So sorry, we're doing this to you, but Saloni, can you just go through the main chief findings and try to wrap up in 5 minutes?
Yes, ma'am. Yes, ma'am. Sure, ma'am. Actually, I'm not able to change my slides.
So for a quick way, you can just exit the screen shows and then, yeah, or you can close and open again. It should work.
Yeah, we can see.
Is it visible now, sir?
Yes, yes, I think it's working well. This is the second slide.
Yeah, so ocular TB might be the first presentation of TB in initially asymptomatic patients. So these are the tests which are routinely done: Montauk, IGRA, plain chest X-ray, CT scan, and PCR from ocular fluids. This study includes the first first 3 tests because they are easily available. CT scan and PCR from ocular fluid are limited to high resource centers. So the COTS, along with the other groups, established to address the existing ambiguity faced by the ophthalmologist for the requirement to start ATT in presumed ocular TB infections. So COTS consensus were developed to consolidate the expertise of 81 uveitis specialists and establish recommendations regarding initiation of ATT in presumed ocular TB. So these were the situations based on SUN classification. which were included, that is tubercular intermediate uveitis, tubercular posterior uveitis, tubercular anterior uveitis, retinal vasculitis, serpiginous-like choroiditis, tuberculoma, choroidal granuloma, choroidal nodule, and tubercular non-serpiginous choroiditis. So there was round one in which 486 clinical scenario-based questions were given to 81 uveitis specialists and via online web-based encrypted link. In the round two, deliberated scenarios where clear-cut consensus did not exist in questionnaire phase were divided into two in-person phases. In the phase one, 71 clinical scenario-based questions were, for initiating ATT was given, which included the tubercular choroiditis phenotype. And in the phase two, 40 clinical scenario-based questions including tubercular anterior uveitis, tubercular intermediate uveitis, tubercular pan-uveitis, and tubercular retinal vasculitis was included. So on the basis of probability that each expert would start ATT in a given scenario, every opinion was awarded a score of 1 to 5 Likert scale, and the statistical analysis was calculated to find the median scores and interquartile ranges. Clinical scenario-based statements with a median score of 4 or high indicated that higher level of confidence that ATT should be started were reviewed in round 2 meetings. So this is the gist of how it was conducted. In the round 1, 486 questions were given to 81 uveitis specialists. In the round 2, phase 1, 71 questions were given to choroiditis lesions and including choroiditis cases. And in the round 2, phase 2, 40 questions were given including the anterior uveitis, intermediate uveitis, vasculitis, and pan-uveitis. On the basis of this, the COTS calculator software was developed. So on the basis of Likert scale, 1 indicated very low probability and 5 indicated very high probability. And in the interquartile range, 0 indicated that more than 90% of the experts indicated absolute consensus to start ATT. So these are some of the results. This is how the COTS calculator looks like. We feed the initial, on the left side, we can see we have to feed initial patient details. On the right side, as seen, we can see the findings are to be filled, which included clinical phenotype, endemicity of the patient, tuberculin skin test, IGRA test, and chest X-ray. On the basis of this, a median score and interquartile range will be available, which will indicate how much possibility of ATT is to be given. So further, tubercular anterior uveitis was classified into first or recurrent episodes. Retinal vasculitis was classified into active or inactive disease, and tubercular choroiditis was classified into tubercular serpiginous, tuberculoma, multifocal or unifocal non-serpiginous choroiditis. So the results included 114 case scenarios with a median score of 5, and of them 72 had interquartile range of 1 and 24 had interquartile range of 0, indicating moderate and absolute consensus respectively. So these are some of the results. First is serpiginous-like choroiditis, where absolute consensus were indicated when both immunological tests and radiological tests were positive, irrespective of the endemicity. In endemic areas, even if one positive immunological test and one positive radiologic test was enough to initiate ATT, and for non-endemic areas, the consensus was moderate. So the conclusion was that only one immunologic test positivity is sufficient to initiate ATT. In cases of choroidal tubercles or tuberculomas, with any immunologic test or alone radiologic evidence in endemic areas, one can initiate ATT. For focal, tubercle, or multifocal choroiditis, immunologic evidence plus radiologic signs of healed or active pulmonary TB. So we have to give ATT in such cases. When both immunological tests and radiological tests are positive, that is an absolute consensus to start ATT. And either of the immunological test is positive with radiological test positivity, irrespective of the endemicity, we have moderate consensus to start ATT. In tubercular anterior uveitis, irrespective of the endemicity, if it is the first episode and all 3 tests are positive, then we have moderate consensus. When it is a recurrent episode and all 3 tests are positive, it is an absolute consensus to start ATT. In posterior uveitis, irrespective of the endemicity, if 2 immunological tests are positive and radiological test is also positive, that is an absolute consensus to start ATT. When one immunological test is positive and radiological test is also positive, we have moderate consensus to start ATT. In cases of intermediate uveitis with 2 immunological tests and 1 radiological test positive, we have moderate consensus And if one of the immunological test positivity with radiological test positive in endemic areas, we have moderate consensus. In cases of retinal vasculitis with the two immunological test positive and radiological test positive in endemic areas, we have absolute consensus. While if one of the immunological test is positive and the radiological test is positive in the endemic area, we have absolute to moderate consensus. If one of the immunological test is positive and the radiological test is positive in a non-endemic area, it is a very weak consensus for to start ATT. The one difference between the COTS calculator and most traditional scoring system is the derivation from two Delphi consensus method, where the experts decided on initiating ATT under 486 different clinical scenarios. Some of the limitations of these studies are treatment recommendations are not provided in this, and it depends on the clinician's ability to identify the phenotype. The initial diagnosis may be wrong, or the other diseases entity might not have been properly ruled out. The validity of chest X-ray, IGRA, and Montauk's test is also questionable, and it is not reviewed by respiratory physicians or other infectious diseases experts who can validate the interpretation of tests. So in conclusion, this COTS calculator holds promising improvement in standard of care for ocular TB. Thank you.
Thank you, Saloni, for trying to stick to time. Who else can we have but Dr. Vishali and also Dr. Salil to discuss this article?
So I'm sorry, for some reason this camera doesn't come on. But my only biggest concern with the calculator, and I wish you had shown the actual calculator in a little more detail, is that it only considers the findings of chest X-ray. We've really moved beyond chest X-ray into HRCT, into PET scans, into EBUS. And honestly, in the West, they have this deep faith in chest X-rays, which any chest physician in India will tell you is probably an obsolete investigation and just needs to be discarded in the bin. I mean, seriously, if patients say that I can't afford a CT, I would say better not do it rather than give us some misleading information. The second thing is, at least out of all those people, 50 to 60% of them are completely from non-endemic areas. And honestly, without offense to anybody, they do not know clinical presentations of TB and how to manage. They're only trying to interpolate from what they may have read in the textbooks as PGs or as fellows. So this entire exercise should have been only done by Vishali Gupta single-handedly.
So, Salil,
seriously, you could have done a better job than all of these people put together.
I'm telling you, it was inadvertently written as chest X-ray, but the calculator has been modified to make it chest imaging.
Yeah.
And we cannot be talking about the PET and all because it was a global consensus. And we have to be sensitive towards countries like Sub-Saharan and many other countries where,
I agree. We should have had much more African representation.
It does have whatever our IUSG members were.
Yeah.
And the second part about it is the application. We are coming up, and Dr. Biswas group actually, Ghazal has done a lot of work on validating this COTS calculator in an Indian setting, and the paper is already under publication. So we will come up with it very soon, how it applies to Indian context.
Correct. Perfect.
All right. Thank you for that interesting debate between Vishali and Salil also. So we move on to the third fast trial by Dr. Sara Rizvi from Bangalore. Dr. Sara, yeah, I see that she's already. Please go ahead.
Am I audible?
Yes, you are.
Yeah, thank you, ma'am. Good evening, one and all. I'll be presenting the article titled Effect of Corticosteroid-Sparing Treatment with Mycophenolate Mofetil versus Methotrexate on Inflammation in Patients with Uveitis. This study was conducted by Dr. S.R. Ratna ma'am and group and was published in JAMA in the year 2019. So we know that steroids are the standard first-line treatment for non-infectious uveitis, and we also know that their long-term use systemic side effects. Methotrexate therapies for uveitis The first-line antimetabolites as steroids-sparing treatment, or the FAST uveitis trial, primarily aimed to compare the effect of MTX and MMF for achieving steroid-sparing control in intermediate, posterior, and pan-uveitis. So they had 216 adults enrolled from in India and abroad between August 23.5 mg per day at month 6. Topical steroids, if given, were tapered to 2 drops or less per day by month 6. And if the patients required periocular intravitreal steroid injections, they were given within the first 90 days of enrollment. The patients were randomized into 2 groups. One group was given methotrexate with an initial dose of 15 mg per week, which was increased to a maintenance dose of 25 mg per week for the remainder of the trial. The other group received MMF with an initial dose of 1 gram per day, increased to 3 gram per day for the rest of the trial. The patients were assessed at baseline 2 weeks and then every 4 weeks up to 6 months. At 6 months, the measurement of primary outcome was done, which was basically control of inflammation. On each visit, the patients were assessed. AC cells were graded as per the SUN guidelines, vitreous haze as per the National Eye Institute scoring system. Retinal and choroidal lesions were assessed by clinical examination and imaging. Macular edema was said to be present if the central macular thickness was more than or equal to 315 microns for spectralis and more than or equal to 300 microns for serous. The primary outcome was control of inflammation, which was defined as less than or equal to 0.5 plus AC cells, 0.5 plus vitreous haze, and no active retinal or choroidal lesion. No more than 7.5 milligram of oral prednisone per day and less than or equal to 2 drops of predacetate per day, and no declaration of treatment failure due to intolerability or safety concerns. 6-month outcome analysis for control of inflammation revealed an overall treatment success was more for the MTX group as compared to the MMF group, but the p-value was not significant. However, for treatment success in posterior uveitis and pan-uveitis, methotrexate had a significantly higher success rate. And in treatment success in intermediate uveitis group, MMF actually had a higher success rate, but the p-value again was not significant. So this is a 6-month primary outcome and sensitivity analysis. The first graph here depicts the overall success rate, which was more favorable for methotrexate. The second graph shows the success rate in patients who were enrolled from India. And here we see that both MMF and methotrexate performed better than MMF. And the last graph here is for the patients who stuck to the treatment protocol, did not miss any doses. For them as well, methotrexate had a better success rate. There was no significant difference in the change in visual acuity, nor was there a significant difference in the change in central subfield macular thickness between the 2 groups. Then 49 of the 68 eligible patients in whom treatment failed in the first 6 months were switched to the other antimetabolite, and they were followed up for a further 6 months. So at the end of 12 months, these patients who switched to the other metabolite, these people had a greater treatment success was seen in patients who switched from MMF to MTX rather than patients who switched from MTX to MMF. So again, and the p-value here was significant. So these are the various outcomes of the studies. I'll be talking about the 2 which had a significant p-value. So methotrexate had a better success rate in the posterior uveitis and the pan-uveitis group. And for patients who switched to the other antimetabolite, patients who switched from MMF to MTX had a better success rate as compared to vice versa. The most common non-serous laboratory event was elevated liver enzymes, which was seen more in the methotrexate group. The non-serous systemic events included fatigue and headache, which were again more common in the methotrexate group. 5 patients had serious drug-related events. All 5 were extremely elevated ALT or AST. And out of these 5, 3 belong to the methotrexate group and 2 belong to the MMF group. So for the uveitis and pan-uveitis group, methotrexate was more effective. A superior success was found in those switching to methotrexate after MMF, and abnormalities in liver function tests were more common with methotrexate. Previous studies have suggested that MMF may be more effective than methotrexate, although the FAST trial proved that MMF compared with methotrexate not result in control of inflammation. Population relevant and common dose of methotrexate, which was equal to 15 mg per. In this study, a higher dose of methotrexate, that is 25 mg per week, was given, which could be responsible for a better performance for methotrexate in the current study. So the FAST trial concluded that the use of MMF compared to methotrexate did not makes methotrexate a reasonable first line choice for an immunomodulatory therapy. However, further needed to determine if either drug. Thank you. Hello.
Hello.
Thank you, Sarah. We request Dr. Ratinam to comment on this.
This is a very important study because the cost of methotrexate is very much economical when we compare with the MMF. Right. So subconsciously, everybody, including myself, we thought MMF will be better. But a very good randomized multi-center study proved beyond doubt that methotrexate is not inferior to MMF. Rather, MMF is inferior to methotrexate. So we were boldly able to start with methotrexate, and only in failed cases we switched over to MMF. And even after switching over, some cases the failure rate with MMF was higher than methotrexate switching. So we were very, very happy to publish this because many patients are able to afford for methotrexate, and if they fail, then we can go to the other drugs like new biologicals. Rather than making the patient spend so much money, it is very, very expensive when we compare with methotrexate. And also the side effects, even MMF produced liver function, even though it is lesser than methotrexate. But anyway, we monitor, and with the highest dose, even with the highest dose, MMF is not superior to methotrexate. That was a very good news.
Thank you, ma'am.
Thank you.
May I make some comment?
Yes, sir.
I just wanted to make my impression. This is not any study or anything like that. My feeling is that methotrexate takes a little longer time to act than mycophenolate. And second thing is that when I give mycophenolate, I give 1 gram 2 times daily. That's a 2 gram per day, not to start 1 gram.
Yes, sir. Yes, sir. I do agree, sir. It acts faster. That is definitely. And to start with, it is better to not 500 BD. That will not work.
Thank you. Thank you very much.
Thank you.
Interest of time, though we enjoyed everybody's talks, but we cheated by going over time. So I'll just go back to hand over to Dr. Padma Malini to thank everyone, and then back to Tinku Bani.
Thank you, Dr. Somshila. At the outset, we thank the RC team for giving us an opportunity to conduct an online webinar for Uveitis For All from the USA end. We thank both the teams. And also I would like to thank Dr. Prashant and Dr. Sudarshan. Both of them have begun this webinar. Unfortunately, they could not join us due to the travel plan. I thank all the speakers for the excellent talk. And in fact, we are so enjoyed. We could not, control, time, reduce the timings. We enjoyed so that, we overshot for too long. And we are extremely sorry about this. But we thank all the speakers and expert panelists for staying back so long for the valuable inputs. I thank Dr. Somshila for co-moderating the session and Dr. Tinku for facilitating this webinar. Thank you. Thank you, one and all. We thank all the participants.
I
Enjoyed.
Thank you, everyone. On
Thank
behalf
you.
of AIOS ARC, I would like to thank the Uveitis Society of India for an excellently crafted webinar that was so insightful and entertaining, informative. Well, we did overshoot the time, but there was such excellent knowledge shared tonight. It was wonderful. Thanks to Dr. Kalpana Babu, President Uveitis Society, for her excellent stewardship, Dr. Padma Malini and Dr. Sudarshan for drafting such a well-balanced program. A special thanks to our stellar panel of experts for their very valuable time and their knowledgeable comments. Thanks to Dr. Jyotirmay Biswas, Dr. Ratinam, Dr. Vaishali Gupta, Dr. Kalpana Babu, Dr. Somvya Basu, and Dr. Salal Mehta. Much appreciated. Thanks to all the speakers. All the talks were superlative and there were some excellent take-home messages. A huge thanks to Dr. Padma Malini and Dr. Somshila for their excellent moderation. Thank you so much. And lastly, thanks to the audience who joined us tonight. I hope it was time well spent for everyone. With that, we come to the conclusion of this webinar, Uveitis For All. I request the audience to watch out for other subspecialty webinars from Team ARC in the near future. So with that, we conclude this webinar. Good night, everyone, and thanks for the great participation.
Good night.
Thank you.
Good night. Thank you.